And what option, ma'am?
The state, because they were asking us
Yeah.
to register,
It is
and
saying others. You just
Ma'am,
put others.
others, yeah,
no, it
Hi,
yeah.
is just there.
Pragya.
Yeah.
Good evening.
Ma'am,
Good evening.
they are working on it. They have made a YouTube channel also, but the studio is trying to work
Three,
on it. Yeah.
two, one. We are
Prob-
live now, ma'am.
Yeah. Thank you so
Good
much.
evening. Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for the Synergy Club Webinar 6 on the topic Intricacies of Antenatal and Labor Monitoring. Before starting the webinar, we would have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Now, I would like to introduce Dr. Monica Singh. Dr. Monica Singh is founder president of ISOVAB chapter of Bhopal. She is national executive member of ISAR. She is vice president of Bhopal Obstetrics and Gynec Society and Bhopal Menopause Society. And also, she is the convener of ISAR Perfection Series, Foxy Symbios Series, and this Synergy Academic Club webinar series. Over to Dr. Monica Singh.
Thank you so much, Dr. Vishal Dave. He is the medical advisor of Intas team and very instrumental in getting our programs forward. And at the outset, I pay my deepest gratitude and regards to all the dignitaries present on the dais, Dr. Naranjana sir, Dr. Pragya Mishra ma'am, Dr. Sneha Bihar ma'am, for being here and sparing your precious time to conduct this episode of Synergy Club, which is the episode 6. And it is our absolute honor and privilege that today we are doing under the banner of Indian Society of Perinatology and Reproductive Biology. Bhopal chapter is the host, and we have, with the kind permission of Tripti Nagaria ma'am and Dr. Jyoti Jaiswal, we have collaborated today with ISOPAB Raipur chapter. If earlier you would recall, when we physically launched the Bhopal ISOPAB chapter, we did it in association with Indore chapter. And very recently, we have also had some interaction with the REBA chapter of ISOPAB. So this is our endeavor to get the societies together and try to give our little bit to ISOPAB in whatever academic activities we can do. So today we will be walking through a very, very interesting topic, that is intricacies of antenatal and labor monitoring. The intrigue behind labor and monitoring of labor never ends. In fact, whole of yesterday and today, we have been in a workshop, TOT workshop of alternative birthing position, which took place in GMC Bhopal, in which today in the labor room of Gandhi Medical College Bhopal, I had the absolute pleasure of watching a patient deliver in the left lateral position and a second patient deliver on the chair in a sitting position. And this made me revise all my obstetrics. And definitely, obstetrics is not complete without antenatal and labor monitoring. So we will be dealing with very, very interesting topics today. We have two distinguished speakers. Mastering the art of assisted breech delivery, the techniques and insights will be taken by Dr. Professor Jyoti Jaiswal from Raipur. And the operative vaginal delivery tips and tricks, they'll be taken by Professor Dr. Arup Kumar Majhi, sir, immediate past president, ISOPA, followed by a very, very interesting panel discussion on fetal surveillance by the very, very expert and thorough, a person with thorough knowledge on the subject, Dr. Sneha Bihar ma'am, in which our expert is Dr. Ruchi Gupta. And we have a galaxy of panelists from all over India. So without wasting time, I'll do the honors and I'll introduce our chief guests and read the CVs so that they can impart their blessings to us. Dr. Naranjana sir, everybody knows him as as the president of ISOPAB, a very, very distinguished gynecologist, head and professor, Department of OBGY, Institute of Postgraduate Medical Education and Research at Kolkata. Sir has got special awards and achievements to his credit. He is the Corion Awardee, ISWAG Awardee, CS Dawn Prize and Medal recipient, former Vice President of the Chairman and Chairman of East Zone of ISOPAB, member of Task Force and Project Advisory Group of ICMR Delhi, peer reviewer of several national and international journals like NEJM, CMAJ, BJOG. Sir has more than 60 publications in NEJM, BJOG, IGGO, JOGR, and others. He has authored several chapters in textbooks with special contributions, tuberculosis in pregnancy and eclampsia. We are so honored to have you, Naranjana sir, and we would be blessed to have a few words from you.
Namaskar. Am I audible?
Yes, sir.
Okay. Good evening. It's a great pleasure for me to be with you once again in this evening. Indeed, the Raipur chapter with Bhopal chapter, they have been organizing this webinar on the intricacies of intrapartum and antepartum care. And this is always a pleasure to talk about practical aspect of perinatal medicine, particularly regarding perinatal care around delivery. I know it should be a great event for us, for all of our trainees, and it will contribute to our learning process. As a president of the society, I have one very important job to do, that expanding the society to the different part of the country. We are now around 4,000 members. In 2024, we are 4,000, and our objective is to reach around 5,000 in 2025. So each of our chapter has to expand with their membership to imbibe, to inspire the young talent to come into the forum, to contribute into the maternal and child health. So I request once again to all of the members of our society, as well as those who are not in our society, to come under the society, so that we follow the dictum of Lord Buddha, Sangham Saranam Gacchami. You become a part of a Sangha. Because what we cannot do alone, a society, an organization, an association can do better. So again, coming together is always a pleasure. And another important request to make, the next national conference is going to happen in Vijayawada. And that will happen on 14th, 15th, and 16th of February. I invite you once, all of you, to join to the national conference in Vijayawada to make it a grand success. Your contribution to the national conference will be greatly appreciated. And again, thank you all the team members of this society, the Bhopal and Raipur chapter of ISOPA, particularly Monica Madam, Neetu, Jyoti Madam, and Tripti Madam, those who are very instrumental to make progress in this area of country. Thank you for organizing this, and my prayer for the grand success of this program. Namaskar.
Monica ma'am, you are mute, ma'am.
Sorry. Thank you so much, Naranjana sir, for the very, very kind words. And definitely, we will keep the flag of ISOPAB flying very high. And it is our honest endeavor, Neetu and everyone, Rachna ma'am, and all the ISOPAB Bhopal team, we try to motivate and make maximum members. At the very first instance, we made more than 32 members, sir. And we have, got, all of us have got the life membership numbers also. Thank you so much, sir. Before I introduce Dr. Sadhna Gupta, ma'am, I'll just break the protocol a little bit because our past president, Dr. Gangadhar Sahu, sir, has just joined us. And we are so honored to have you, sir. Dr. Neetu, communicated to me that sir is joining. I said we are very lucky to have Narayan sir, as well as Maji sir, as well as, Gangadhar Sahu sir with us. And I always look forward to his messages in the morning. Very nice quotations sir shares with us. Sir was the president ISOPAB in 22-23. Sir is retired professor HOD, VSS Medical College, Burla, Sambalpur, where a very nice conference of ISOPAB was held recently. Sir was also ex-Dean IMS and SUM Hospital Bhubaneswar, ex-Vice Chancellor SO University Bhubaneswar, and founder president of the Burla Sambalpur chapter of ISOPAP. Sir is the founder national president of 11 chapters of ISOPAP, including the Raipur chapter. So Raipur team must be so happy today to have Sir in our midst. Sir got the Best Teacher Award in 2013, Best Orator Award in 11 and 16, and Papinicono Samman in 23 for operating more than 1,000 cases of gynec cancers. Sir is a passionate teacher, versatile orator, a healer with a healing touch, a preacher of human values, published 2 books on my thoughts, a big philosopher, prolific writer, a leader who leads from front and takes all the team along with him, a disciplined and friendly administrator with great principles in life like discipline, live rich but don't die rich. The dream is to be a ladder of success for others to climb up, always lends a helping hand, and has a mission to create a generation of complete physicians who know what holistic treatment is. Sir considers himself as a grassroots worker, though he has reached the stars, and he considers himself as an ordinary human being who is surrounded by extraordinary friends and well-wishers. This is such a beautiful CV, sir. We would like to have a few words from you, sir.
Thank you, madam. So I am it is my surprise appearance in your webinar. Actually, what you said that Nitu has personally invited me that you should be a part of this seminar. And then I say I'm fortunate enough to at least have an interaction with Monica madam and other great stalwarts of ISOPAR who are present there. So Sadhana madam, sorry I took your time. So only few words regarding that the ISOPAR is growing. Now it is in the motion mode. Nobody can check it. Only you have to add fuel to it and your spirit that will act as a driving force for the movement and growth of ISOPAR. So Monica madam, your chapter is a part of it. I hope you will maintain that. ISOPAR chapter Raipur is very close to my heart because she is one of my 11 children born during my tenure. So I am happy that ISOPAR chapter is taking part. So also Binu madam and her chapter that was also born during my tenure. And I am happy that all these grades like Tripti madam and Arup Maji and also so many other speakers, panelists, and Sneha madam is also participating now as a moderator.
Yes. Sir,
Okay.
good evening. Pranam, sir.
So all my very, very loving, what I can say, my just like my children. So they are participating and I am so happy to be a part of it. So I wish that along with ISOPAR, all the chapters must contribute something. And I want that from every chapter, there should be a hardcore ISOPARvian, at least one. And if one hardcore ISOPARvian I will get from each chapter, the ISOPAR will grow like anything. Another thing I always tell, give 15 minutes of your life daily towards ISOPAR. And you will see the change of face of ISOPAR after a few years. That is not difficult, but this requires your attitude. Next is, I wish that long live ISOPAR, long live ISOPAR, long live ISOPAR. And long live Bhopal and Raipur chapters of ISOPAR. Thank you very much. Wish your webinar a great success and with intelligential, very productive interaction and take home messages. Wish you all again all the best. Pray Lord Jagannath to bless all of you with your family and friends. Greetings from my family, Odisha and my Burla Sambalpur chapter, and blessings from Lord Jagannath. Again, namaskar to all of you.
Thank you so much for the kind words and blessings, Sahu sir. You have taken out time to be with us this evening, and we are really, really honored to have your benign presence with us. Sir, I would now like to introduce our chief guest, Dr. Sadhana Gupta. who has kindly consented to be in this program despite her busy schedule. We all know what a wave she has created by her election campaign last year and last year. And Madam has recently been awarded the ICOG Vice Chair Elect Post 2025. Congratulations, Sadhna ma'am. Sadhna ma'am is active everywhere. She has always been a gold medalist and achiever. And she is working in the city of Gorakhpur with special interest in almost all areas of obstetric gynecology, high-risk pregnancy, operative obstetrics, holistic reproductive health, as well as infertility. So, madam, I would your CV is very, ma'am, impressive.
Okay,
I
it's
think
okay.
I will just, ma'am, like to highlight the APJ Abdul Kalam Life Achievement Award of 2023, which is a very big honor, ma'am. The Economic Award of 21, the MS Signature Award, a great recipient of the DC Datta Prize 3 times and Corion awardee with several papers to her credit. She is full of energy. I see Madam everywhere with a passion too. And this time we were in the ISAR master class where we were formulating guidelines for RPL. Madam's group, I was there in Madam's group. And Madam had the most amazing contribution and suggestions to RPL and its management. We are blessed to have you with us, Sadhna ma'am. And we would love to have a few words of wisdom from you, ma'am.
Thank you, Monica. First of all, my sincere regards to great seniors and the great teachers, Dr. Gangadhar Sahu, Dr. Arup Maji, Dr. Narayan Jana, and our all office bearers are there. Hearty congratulations, Monica, for taking this initiative that we had added one more member. And ISOPAR is something, we have a very loving family where we have great teachers, great academicians, and the great persons who really teach us the right ways for the life. So a lot of inspiration we have drawn, and we will continue to have this legacy. And it's great that we have added another chapter, yet another chapter, and you are going to do the great job. Rest assured for it. With my all regard to and the thanks for this invite, the special guest Veenu Pushpa, Pragya, very dear friend Trapti, and Neetu, Purva, and Nandini, who are the convener of this program. Thank you for all reminding call. You are choosing the first inaugural program with a very something courageous theme. Where you are putting the assisted breech delivery and the operative vagina delivery at the forefront. And the speakers are greater, they must be very good and great to have this interest on these issues, especially for the new generation obstetrician. So Dr. Jyoti and Dr. Arup Kumar Mauji, so they are going to teach a lot. It is always actually what is the crux of the obstetrics, art of obstetric, what we say. This is the assisted breech delivery. This is the operative vagina delivery, where we really know what we are doing, in which direction, in what force, and it is actually the teaching for life. So it is a care, it should be gentle, it should be very well directed, it should have only the necessary force and not before, and we should leave everybody uninjured, healthy. So I think this is the philosophy of life which we have to inculcate, and it is a philosophy of obstetrics. So going to listen, everybody is going to learn a great thing from Dr. Arup and Dr. Jyoti, and with all the chairpersons. And the panel discussion, Sneha, a wonderful academician and a person, and herself, she is a hardcore obstetrician. So the fetal surveillance, which is again, we are really we're having the swing between how much technology, how to interpret technology, and how to make technology beneficial for everyone, for the mother, for the fetus, and for the obstetrician and obstetric care team. So it is something very courageous thing, and the ISOPAR can do it because we have a wonderful legions of teachers in the ISOPAR. So thank you once again very much for this invite. My all heart best wishes to your chapter. We are always there for together for any program, and we want to that you also join any program we organize at the national level, zonal level, and in our society. So thank you very much, and all the best.
Thank you. Thank you so much, Sadhna ma'am. And I would like now my dear friend from REWA, ISOPAP chapter REWA, Dr. Binu Kushwaha, to do the honors. And Binu, I will read your CV later, but since Pragya ma'am is a little bit in a hurry, so could you please do the honors and introduce Pragya Mishra ma'am for
Sure,
us?
ma'am. Sure. Good
Yeah.
evening, everyone. And I truly feel blessed to be seen there on screen between all the stalwarts of ISOPUB. And thanks, Monica ma'am, for giving me this opportunity. Pragya ma'am is a very dear, I would not say friend, but she's kind of a friend to me. So it's my pleasure to introduce her. She is a consultant in fertility specialist at New Life Test Tube Baby Center and MGM Hospital and Research Center Private Limited, Patna. She's Secretary General of ISOPAP 22 to 24 and ICOG Governing Council member. She's Chairperson, Genetic and Fetal Medicine Committee, FOXY, from 2016 and 2018. She was Founder Secretary of Bihar Chapter of ISAR, Vice President, Patna Ops and Gynae Society 21-22, Secretary Patna Ops and Gynae Society 1920, examiner for MRCOG examinations, and she also imparts FOXY certified colposcopy training. There are so many things to be read. I would just say that she was awarded with Dr. J. Mishra Gold Medal in 18th and 20th BoxCon, and then awarded Dr. MP John Gold Medal in 13 BoxCon, awarded CL Javeri Award at 57th AICOG 2014 Patna. Pragya ma'am, there are so many.
Yeah.
I welcome you to please put forward some words of
Thank you,
wisdom for us.
thank you, Dr. Binu. I would just say that, I'm the president-elect of Patna Obs and Gynae Society, taking over as president on 14th. And I just recently organized Yuva ISAR, 10th National Yuva ISAR. And I think one of my most recent achievements is that I think I'm the only gynecologist in Bihar who has received fellowship of the American College of Obstetricians and Gynecologists. So these are my
Wow,
recent.
ma'am, great to know that.
Yeah, and I just took your name today because I had been invited for this IMS presidential webinar series to give a lecture, and I quoted a paper from you because my talk was on CIN in postmenopausal women, and I found that, and I showed that paper which you had contributed regarding the Swede scoring. So I just took your name in the webinar today. So good evening to all of you.
Congratulations, Pragya, for your upcoming achievements, and see you to rise high. Sky is the limit.
Thank you so much.
Right.
And and of course, I should not, then in that case, I should not fail to mention that what a wonderful conference you all had given us this time in Jharsuguda. And just a memorable conference indeed. So, chief guest of today's program, Dr. Narayan Jana and Dr. Sadhna Gupta. Of course, Dr. Monica Singh has given such a wonderful introduction of Dr. Sadhna Gupta, and you as special guest, Dr. Binu, and co-guest of honor, Dr. Tripti Nagaria, and convener, Dr. Monica Singh, and the program coordinators, Dr. Neetu Mishra, along with Dr. Purva Batkur and Dr. Nandini Singh. All of you, when I can see that, this webinar is so, although, there have been today, I think almost 5 to 6 webinars are running back to back today. I don't know why 10th of December had been chosen for ISAR and for ISOPAB, for IMS, and so many other webinars, today. So, but first of all, I would like to congratulate Bhopal chapter of ISOPAB, which was born in front of me in my, it was just last year, not last year, actually this year, just before the conference that we had in Raipur, which was organized by Dr. Tripti Nagaria and Dr. Jyoti Jaiswal. So we can see how much of interest. It's very nice to see Dr. Monica Singh and team are taking so much of interest in ISOPAB. And and I'm sure that she is going to take the flag of ISOPAB higher. There's no doubt about it. And Dr. Narayan Jana already mentioned that we have almost 4,000 members and approximately 45 city chapters, and we are aiming that at least, so my message as secretary general would be that each one make one. I think if you just do that, if you just motivate one of your friends or colleague to become a member of ISOPAB, we can just double the membership strength of ISOPAB. And it's really nice, because well, in front of me, Riva chapter was also born with and all the presidents who have been instrumental. They are also, because I can see all of them right in front of me, Dr. Gangadhar Sahu and Dr. Arup Majhi and Dr. Narayan Jana. So one by one, all these, because Dr. Sahu was instrumental with Raipur chapter. Dr. Arup Majhi was, and Dr. Sahu was actually instrumental with the Riva chapter also, and Dr. Majhi and Dr. Jana with the Bhopal chapter of ISOPAB. So it's been, I mean, it's been quite wonderful, to have worked with all these presidents. I think the best presidents of ISOPAB, are right sitting in front of us today. I congratulate Bhopal chapter for doing this together with the Raipur and Raipur chapter of ISOPAB, and congratulate mainly for the topic which you have selected, intricacies of the antenatal and labor monitoring, so pertinent to ISOPAB, because ISOPAB is the only professional organization which caters to both perinatology and reproductive biology also together. So I can, and secondly, as secretary, apart from membership strength, a very small request, it's actually a very small request, that I would appeal to the city chapters, presidents and secretaries, that please do not forget to contribute towards the annual subscription of ISOPAB, which is just a very small amount of 5,000 rupees if you are less than 100 members, and 10,000 rupees if you're more than 100 members, which has to be, several reminders have been sent out from the head office. So, but I do understand Bhopal has not finished even 1 year, but other chapter presidents who have logged in and have finished, I would request them to please make your contributions, because, the office also has to run. We have quite a few people, almost half a dozen people working in the office to keep things running smoothly, because, keep getting phone calls from all over the country for this problem, that problem. So we need a team, and to make that office running, we need your contributions. So just these two things I would like to say, and it seems to be my best wishes for a wonderful webinar, and I'm sure you're going to keep it up, and you will have lots to offer in future also. So thank you so much for having invited me as a guest of honor today.
Thank you, Pragya ma'am. And that was a very, very elaborate message you had for all the ISOPABians. And we will surely keep all your instructions in mind. And we would try to do the best for our organization. Ma'am, the person who introduced you is Dr. Professor Binu Kushwaha. She is a very dear friend. And I would like to do honors by introducing her. She is an alumnus of the prestigious Gajra Raja Medical College of Gwalior, and she did a post-graduation from Lady Hardinge, Delhi. She's always been a brilliant student. So besides getting the Best Girl Student Award of MBBS 96 batch, she's also been awarded the FIGO Journal Best Original Research Article Award on Medical Abortion, known as the John J. Sciarra Award, as well as Silver Medal for Paper Presentation in AOGD. She's also got the Kamini Rao Orator of the Year Award in 15, Korean Award in Senior category in 17, as well as an MP State Appreciation Award for providing quality CAC training for of trainers for 10 years. Though she looks very young, but she is a very, very senior faculty in Riva Medical College and a thorough academician, a very friendly person. And one very, she has got a very great extracurricular hobby, and that is reading. I think she likes poetry, and she often surprises us with very deep poetry, with very meaningful poetry. I think the poetry reflects your mood, Binu. When she's happy, she'll write happy poems, and when she's, little pensive, she'll write those. So, I mean, it's very, very touching, your words and the way you express it. So, Binu, a few words from you, please.
Yeah, thank you so much, ma'am. As I said, that I really feel honored and blessed to be seen there among all the stalwarts. That was one thing. And I'm truly thankful to Gangadhar sir and Pragya ma'am, who actually were the part of our installation ceremony of our society and we started with 36 members. And the unique thing about our chapter is that it includes 5 cities of this region. So the chapter's name is Vindhya chapter. It's not really Riva chapter. Riva is one of the city. So I have included 5 cities in that chapter. So that is the unique part. And Gangadhar sir and Pragya ma'am have been instrumental in the formation of our society. I'm very
Actually,
thankful
that
to them.
Vindhya wasn't coming in on, it was inside, but I somehow it could not just come out. I wanted to say Vindhya, Dr. Binu, but
Yes,
I
ma'am,
thought
because
Riva
that is
was,
close to my heart. It
yeah,
consists
yeah.
of 5 cities, so we took lots of pain to create it. That is how. But ma'am, you and sir really supported us well, and Sadhana Gupta ma'am was the guest of honor in our installation ceremony. So I'm seeing all of them there. It feels really great. But the thing, yes, I would accept that I have not been able to do in the form of webinars much in last year, but we did lots of activities actually at our place, physical seminars, and also we release actually 3 monthly quarterly newsletter also of ISOPUB Vindhya chapter regularly. I would share that in our groups also. So that is one thing that we do, and we would definitely try to do some webinars also. And the topic which Dr. Monica Singh has chosen is really near to my heart, because nowadays students really are not interested in obstetrics. So I emphasize being a student of Lady Harding, which is known to impart very quality education and skill in the field of obstetrics. I have seen the teachers who were like dream teachers in the field of obstetrics, and when now I see that the students have no interest in obstetrics, it feels bad. So especially to introduce this assisted breech delivery and the operative, these are two parts which are, nowadays they are coming up again, because we are now focusing on reducing cesarean sections. So breech delivery should be known to every student. RCOG has categorically said that no more breech is an indication for cesarean section, and where the expertise are available, they can very well be delivered vaginally. So I congratulate Dr. Monica Singh to, take up this topic. And thanks to everyone for making me a part of this webinar. Thank you so much. Thank you.
Thank you, Binu, for joining us today as special guest. And you are very special. And next, I would like to introduce our guest of honor, Dr. Tripti Nagaria, ma'am. Can I have her CV, please? Madam is the president of ISOPUB Raipur chapter. We are so honored to have you amongst us, madam, today. She is Dean CCM Government Medical College, Durg, past State Secretary of the Associations of Societies of OBGYN Chhattisgarh, past Secretary of ISAR Chhattisgarh chapter, past Secretary of IMS Raipur branch, past President of Raipur Society of OBGY. She has published 32 papers, contributed 8 chapters in books, and was also the corresponding national editor of Jogi. She is the recipient of Global Signature Award, invited faculty in more than 150 conferences, the organizing chairperson of the very, very successful National Conference of ISOPUB, which was held in Raipur in the last week of April 2024. And she has organized international conference forums, national ISAR, IMS, state conferences, workshops, and CMEs. We are very honored to have you, Tripti ma'am. We would like to have a few words from you about our program.
This is an honor to me, really a great, because to share this such an stalwart people who have joined already this webinar. Good evening to all. Dr. Jaina. sir, Dr. Sahu sir, Dr. Satya ma'am, Ritu ma'am, Radha ma'am, and Sneha, and all. It's an honor, really great honor. And when sir says something about us, we feel so glad that, of course, we had been nurtured by Dr. Sahu sir throughout the period when we were installing our ISOPOP, and also while we were organizing the national conference, the guidance which we have received from Dr. Bhaji sir, Dr. Satya ma'am, and as well as Dr. Gangadhar Rao sir. The key they have supported us like a small kid, really. And so we are happy to have the guidance of all the drivers by the next conference. And thank you for the kind words which they have said about us. Today, I must congratulate the Paul Gopal branch, Gopal chapter of ISOPA, who have very well organized this webinar, because this is the need of the day. Let us not forget the art of the BBB, because once a brief, the usual thing that the person is counseled in such a manner that she agrees for the civil section. On the contrary, we had also conducted one study speech, vaginal versus civil section, and we have found that there is not difference between the two. And in fact, if the baby can be delivered vaginal, it's better for the baby as well as for the mother. So we should not forget this part, and I'm sure our learned speakers will discuss this and will teach us so many tips about the BBB, and all those who are in the audience, they will be learning a lot from them. At the same time, the subject that for health is the main very important in the today's scenario. And I know Dr. Sneha personally, she's a wonderful person, and everybody would be very much eager to listen from all this, and will be able to get into the webinar always whenever they are there, because these are the things nowadays when you are spreading the knowledge just the net surfaces. It's so important that, and the people are there getting their time to speak to. The only thing is that you have that need to learn from the small tips which are going to change the whole practice. So thank you so much for inviting me into today's webinar and for giving me this honor. And again, once again, I congratulate for the new chapter, as well as my best wishes for the ISOPA. Thank you so much.
Thank you. Thank you, Tripti ma'am. Thank you for your presence. And thank you for giving us permission to do this webinar with the Raipur chapter. And now any building which is made is built on the foundation of pillars. So these are the 3 pillars of Bhopal ISOPAP chapter, who have built up not only the synergy program, but so many academic programs that we continuously keep doing. They are Dr. Neetu Mishra, Associate Professor, Department of OBGY, AIIMS Bhopal. Dr. Purva Bhatkur, Assistant Professor, Department of OBGY, GMC Bhopal. And Dr. Nandini Bhati, Assistant Professor, GMC Bhopal. They are all very, very accomplished, dynamic, and passionate about academics, these gynecologists, and they have a long way to go. I think the path which we are forging ahead will be taken to the highest summit by these 3 young ladies. So kindly start the program, Dr. Neetu.
Yes, ma'am. Thank you so much, ma'am. Now we will move ahead with our scientific program. In this session, the first talk will be by Dr. Jyoti Jaiswal, ma'am. She will be delivering her lecture on mastering the art of assisted breech delivery, techniques and insight. To chair this session, we have 3 chairpersons, Dr. Monica Singh, ma'am. She is president of Bhopal chapter of ISOPA, as well as convener of this program. Our next chairperson is Dr. Rachna Dubey, madam. Can I have a CV, please? Dr. Rachna Dubey, ma'am, she is director, Health, IEC, and State Nodal for Preventive Gynae, Oncology and Infertility. She is also Center in Charge, State of Art Center for Preventive Gynae, Oncology and Infertility, Government of Kailash Nath, Kadzu Hospital, Bhopal. She has many achievements in publication, including she has screened 6,000 plus women for cervical cancer in last 2 years, and 2,000 plus women were enrolled under any government sector of PCOS. She has also represented India in Harvard School of Public Health USA in June 2023 as Emerging Women Executive in Healthcare and Preventive Gynecology Program. She has so many special awards and recognitions in her bag, which includes National Award for Outstanding Initiative for Promoting Women Healthcare Services in Government Sector, felicitated by Public Relations Society of India. And she has also been awarded with ISAR Distinguished Services Award for Women's Health by Honorable Governor of Madhya Pradesh in February 2023. We are honored to have you, ma'am, as panelist for the panel discussion. Our next panelist is Dr. Shabana Sultan, ma'am. She is currently professor and head of the Department of OBGYN.
Neetu, chairperson.
Chair-
Yes.
Okay, sorry, so sorry. To chair this session, we have chairperson Dr. Shabana Sultan, ma'am. She is professor and head of the department, Obstetrics and Gynae, Gandhi Medical College, Bhopal. She is also the secretary of Bhopal OBGYN Society and ISOPAB chapter of Bhopal chapter of ISOPAB. She has many posts in Bhopal OBGYN Society and Menopausal Society. And we are honored to have you as chairperson for this session. Now I hand over the session to our chairperson to introduce our speaker, Dr. Jyoti Jaiswal, ma'am, and carry forward the session.
So,
May I do the honors, Monica Didi?
Yes, sure, Shabana.
Yeah.
Can I take her CV?
So it's my pleasure to introduce, she is my friend also, Dr. Jyoti Jaiswal. She is presently working as professor and head of the department, JLM Medical College, Raipur. And she is also secretary of Journal ISOPAB Raipur chapter and vice president is SAR Chhattisgarh. And she has organized many national conferences, in which last ISOPAB conference in Chhattisgarh. Also, she has many awards, national, international, and one is MS Signature Award to her credit. And so many international and national publication to her credit, and she is a great teacher. So over to you, Jyoti, for your talk on mastering art of assisted breech delivery. That's a very important topic.
Good evening, one and all. I special namaste to Gangadhar Sahu sir, Jana sir, Pragya madam, and all my chairpersons, all guest of honors, Binu madam, Nagaria madam. This is really a privilege for me, and I am honored to be in front of you. That breech delivery presentations I have seen from my teacher, and today I am presenting in front of her. So this is a great thing for me. Can I share my screen, please? Madam, is it visible now?
Yes.
Make it full screen.
I'm trying to make it full screen. Is it full screen now, sir?
Yes,
Yes.
Dr.
Very
Jyoti.
nice.
Okay. So today my topic is little bit focused, not completely totally about the breech delivery, but specifically for the assisted breech delivery techniques and the insights. So to start with, the definition was the breech presentation is, it is the fetus in a longitudinal lie and the pedalic pole presents at the pelvic brim. It is simply the breech. And what is assisted breech? It is the vaginal delivery method that involves helping the infant deliver the remainder of their body after they have spontaneously delivered up to the umbilicus. So we need to just assist. We do not need to extract. Incidence, we all know that it decreases with the increasing of gestational age. So as to, we need to take care when we are going to diagnose the breech presentations. These are the various presentations of the breech: frank, complete, incompletely complete, and footling, kneeling presentations. These are the pictures showing the complete breech where all the things are completely flexed. And this is frank breech, where the splinting action of the legs remain there and the legs remain extended beside the rest of the body of the fetus. It is common in the primigravida, and complete breech is common in the multigravida. Looking at the clinical varieties, when we see that any breech can be uncomplicated or complicated. Uncomplicated breech is defined as one where there is no other associated obstetric complication except from the breech presentation, prematurity being excluded. The complicated breech presentation is associated with the conditions which adversely influence the prognosis, such as prematurity, twins, contracted pelvis, placenta previa, and many other things. The extended legs, extended arms, cord prolapse, or difficulty during breech delivery should not be called complicated breech, but are called abnormal or complicated breech delivery, because we used to come to know only during the procedure, not at the beginning of the process. So, directly coming to what precautions we should make when we are going to plan a delivery as a breech vaginal birth. Labor to be conducted in a hospital where all the facilities of the cesarean section are available. IV infusions must be set up with large bore cannulas, because these may lend up sometimes into the operative delivery, sometimes for extension, and we may need to manage them. There should be continuous facility for continuous electronic fetal monitoring. Epidural anesthesia may be beneficial. It is not mandatory, but it may be beneficial, especially where because it can have the chances of landing up into the operative delivery. An experienced midwife or obstetrician must be available. So I will not say midwife at present. I will say the experienced obstetrician must be present there to deal with it. Also, we should keep it in mind about the risk factors, whether they are maternal, placental, or fetal, because in many conditions, which are the risk factors, are associated with the breech, where the breech vaginal birth is contraindicated, like contracted maternal pelvis, and if the baby's size is, if the cord prolapse is there. So all risk factors we should see, identify, and then when we are planning that yes, this patient can be allowed for the vaginal birth, then only we should move ahead. Before that, physical examination comes. On transabdominal examination of the lower uterine segment, breech presentation is characterized by the presence of a soft mass and the absence of a hard fetal skull. Normally, usually in the vertex presentation, the cephalic presentation, we find a globular fetal hard part, that is head. In addition to that, a hollow fetal neck, which is very important to identify, next to the presenting part is absent. So this suggests a breech presentation, and this curvature or a notch usually remain palpable in a cephalic presentation. On examination of the fundal part, which is really helps us in diagnosing, the fetal head can be readily ballotted since it pivots on the neck and moves independently from the trunk. But sometimes even in the breech presentation, this clearly ballotable head may not remain that clearly identified, especially if a newcomer is trying to identify, especially if the patient is a primey with the extended leg frank breech. So that works as a splint, and sometimes that can cause a diagnostic dilemma. In comparison to the cephalic presentation, otherwise, the ballotment of the breech in the upper part of the uterus is typically sluggish. And because it is accompanied by the movement of the entire trunk, so that usually we become able to identify. On transvaginal examination, the soft buttocks, the anal orifice, or feet may be identified, but it is only possible when the cervix is dilated and the membranes are not there. Otherwise, it can be difficult to palpate when the cervix is closed and the foot is differentiated from a hand by the presence of the heel. While palpating, a fist or a grasp may identify a hand. So when we were students, these tips like the feel of the heel and the grasping of the hand, these were the typical things which used to be taught for identification of the presentation. Nowadays, it is the era of the ultrasound, and majority of the pregnancies, they are already diagnosed that what presentation is it is. So ultrasound clearly identifies the fetal head in the fundus, buttocks in the lower uterine segment, extension, flexion, whatever. It is very clear cut nowadays. But our clinical sense should also be there if we do not have these facilities or the prior ultrasound. In ultrasound, we can see one more thing, the hyperextension of fetal head defined by an extension angle greater than 90 degree. It is important finding, as in any imaging, if we are finding that extension angle is greater than 90 degrees, it contraindicates for the vaginal birth because of the extension of at the level of neck. So coming to the planning, how we plan for the delivery. So I will not go here in detail. The three things are there after 36 weeks. One can go for the ECV or the planned elective cesarean section depending on the situations, or the planned trial of assisted breech vaginal delivery. So I will focus on the planned trial of assisted breech vaginal birth. We need to perform cesarean section if we already know that it is a footling breech presentation, the case is of previous cesarean section, case is having the poorer outcome in the past, and associated obstetric problem if there is any, and suspected cephalopelvic disproportion is there. Estimated fetal more than 3.5 kg, some books write 3.8 kg, are a relative contraindication depending on the size of the pelvis. But yes, as it is not a very common thing to perform breech delivery electively in a good size baby, so definitely not more than 3.8, rather we restrict on 3.5. There are some studies which gives us the criteria for selecting the women who are the low risk, which can be planned for the vaginal breech birth. So they should have the normal pelvimetry. They should not have the hyperextension of the fetal head, which we have just discussed on the imaging, and estimated fetal weight 2.5 to 3.5, I will say. Frank breech presentation, continuous use of electronic fetal monitoring availability, and yes, patient should also agree for the vaginal breech birth. When we are talking about the pelvimetry, so the standard we know that 12 centimeter of the transverse diameter, 10.5 anteroposterior, and 10 centimeter interspinous diameter should be there. And apart from that, yes, according to the size of the baby, we need to assess the pelvis. So coming next, that if the patient we are allowing for planned breech vaginal birth, so what we should see in first stage of labor, we should set up an IV line to keep for the maintenance or for to deal with any emergency, keep prepared for possible cesarean section. During every vaginal examination, feel for possible cord prolapse or presentation, and especially at the time of the rupture of the membrane. Do not do ARM until it is in advanced labor. Perform vaginal examination immediately after membranes have ruptured to exclude cord prolapse and to assess the cervical dilatation and level of presenting part. Because seeing at the progress of labor is also important. If the progress of labor is delayed, in that case also there are high chances for landing into the operative and the complications, so that it's better to go for cesarean. Assess fetal heart rate carefully during labor. Avoid premature pushing. No pushing should occur until the buttocks are descending the perineum. So our teachers were also used to tell that keep your hands off. Don't pull anything. Let the buttocks come spontaneously. Let the most of the back also come spontaneously. There should be adequate analgesia should be given. If she starts to push before cervix is fully dilated, in that case, we should advise her not to push. And sometimes if very strong contractions are there, we should be ready with the with intravenous pethidine and then later on for the naloxone for the baby. This is not a routine practice though. Assess progress of labor every 2 hours in active phase. This includes rate of cervical dilatation as well as descent of the breech. Oxytocin may be used if contractions are weak, but consultant or a senior person should be advising the oxytocin. It should not be as a routine. There are few things which it gives us insight then when and what to be done. Like if we need labor augmentation in the first stage or in the second stage, or if the second stage is more than 1 hour, usually these births are associated with the poorer outcome. So in that case, be prepared for cesarean section if progress is not satisfactory, and do not allow the progress of labor to go to the right side of the action line. These are the in general rules otherwise also. So we should not be very this thing in vaginal birth karana hi hai, so we are waiting. So these things we have to keep in mind. Now what to be spatial things should be keep in mind while the second stage of labor. The second stage of labor and breech delivery remains in like 2 part. One where the assisted breech delivery, where just we need to assist the rest of the body automatically coming down. And the second is breech extraction, which is only in certain conditions we allow. Otherwise, we do not go for the breech extraction. You see, most of the babies are delivered by the maternal effort alone, and the attendants deliver. Attendants mean the conducting obstetrician delivers the head and the shoulder. So while taking this patient, we should keep in the second stage of labor when she is pushing. Patient should be kept in lithotomy. She should be changed from the dorsal to lithotomy, and rather she should be kept, should be brought up to the edges of the table so she can, so the maneuvers becomes easy. The bladder should be emptied. The initial use of hands-off policy, do not pull down policy is very important. Also avoid spontaneous vaginal delivery, because if the delivery of the head is uncontrolled, there is risk of injury to the brain. So both things are important. Initially, you do not haste to pull down, and later on after up to the delivery of the shoulder, after that you need not to leave the baby. You have to be there for support, because if suddenly she pulls down, there will be sudden decompression of head, and in that case the perineal injuries will be more and the fetal head injury will also be more. Keep infiltrated the perineum in case episiotomy is required, and elective episiotomy is not required in each and every case. But if the baby is premature, so in that case, for the sudden, so the prevention of the sudden escape of the presenting parts, fetal head, for that, even though the baby is smaller, we may need a little bit of episiotomy. And preparation of definitely cesarean section if there is no descent of the breech. So coming to how we should see when the breech is spontaneously coming out. The patient is already at the edge of the table. The patient is having good contractions. We have to ensure the good contractions and we have to remain there. Woman is allowed to push with each contraction and the buttocks are delivered spontaneously. As you can see in the picture, the buttocks are being delivered spontaneously and it is the extended leg. Even then the legs are coming out. If the legs are flexed, they will automatically fall out. But if they are extended, sometimes we need to apply pressure in the popliteal fossa. So you can see in the picture down how to apply the pressure in the popliteal fossa. So apply the pressure in the popliteal fossa, flex at the knee joint, keep it the external rotation at the hip joint and sweep out the leg. Ensure the fetal back is the uppermost, means anteriorly, and if it turns downwards, it will cause problems. The chin will catch under the symphysis pubis and the difficulty delivery will be very difficult for the head and then we may need to go for the Prague maneuver, and the injury to the perineum and delay in the delivery usually happens in such cases. Now the body, the buttocks, the half of the legs and the back is come. Now it is the turn for the arms. So usually after the half delivery of the trunk, we used to check for that cord is not stretching. There should not be stretch of the cord. The loose hanging cord should be there. We can see that hands are in front of the chest. They are flexed, so they will come easily without any manipulation. Just to hook them, press behind the humerus at the elbow, and they will come down. But after if the hands are not there in the hollow of the sacrum, in that situation we can identify this with the winging of the scapula. If it is the winging of the scapula, then we know that arm is extended. So in case of the extension of the arm, there are few maneuvers, and these maneuvers to be done. For the here I am describing the head is delivery of the head. If head is delivered slowly by placing one finger in the head should be allowed for the slow delivery. Till the delivery of the shoulder, there is no haste. But after the delivery of the rest of the body and head is inside, we do not have much of the time. Still, we do not need to pull the head in such situation, because if the head is not coming down into the perineum and we'll pull, there are chances for the injury at the level of neck. So do not allow the sudden pulling. Rather, you allow the baby to hang by its own weight, and you can just support. You cannot have a very, very long time also. So there is, you can help by the suprapubic pressure, and can maintain the flexion of the head further. Head should not be popped out suddenly also, because as I said, that sudden decompression can cause the problem. Here I am showing the pictures of the delivery of the arm. The arm across the chest, if they are there, they will deliver spontaneously as the anterior shoulder blade appears. And the place two fingers to the appropriate hand. If we need to remove the right hand, use your fingers of the right hand. You need to remove the left hand of the baby. You try to use your two fingers of the left hand, and you can sweep over from the clavicle around the shoulder and down the humerus to the forearm to bring it down. Delivery of the extended shoulders sometimes can be helped out with the help of the Lowset maneuver. The Lowset maneuver is a simple maneuver of rotating the baby to the 180 degree, bringing one shoulder anteriorly so that it comes beneath the symphysis pubis, and we can take it out and then make the posterior shoulder to the anterior. In the upper picture you can see, by rotating it by 180 degree, make the posterior shoulder anterior, and now the anterior shoulder comes out of the symphysis pubis. Sweeping of the arm over the face can be done even if it is not corrected by the Lowset maneuver. In that case, we can go from we can enter our hand through the hollow of the sacrum and can sweep over the hand over the face. Coming to the delivery of the fetal head, there are several methods described. The common method is Bern-Marshall and Mauritius-Mealy-Wheat method, and sometimes the forceps delivery also can be done, and it is really helpful when the other methods are not working. So these pictures are showing the Bern-Marshall maneuver, where we need to allow the baby to hang by its own weight. Just be there to support. As soon as the nape of neck is visible below the symphysis, with the wide arc, we can pull the baby and keep it on the abdomen of the mother. And by moving this, the head is coming out through the perineum. But if we are taking this extension application when the nape of the neck is not there, hairline is not visible. In that situation, the head is not coming down in the perineum, and it can cause the injury to the atlantoaxial joint. So there should not be a haste. The another method is Mauritius Milliwheat maneuver, where like making an asterisk, we keep the baby on our hand, keeping both the legs and both the arms on our one hand, and the second hand helps in pressing the head and maintaining the flexion, and the lower hand, the two fingers of the lower hand tries to keep the malar flexion. So this is also known as malar flexion, and the shoulder traction. Nowadays, not a shoulder traction, actually flexion of the head is remain there. These pictures are also suggesting that when we keep the baby towards the maternal abdomen, see the changes in the pelvic area and the hyperextension of the thighs of the mother also helps in keeping the vaginal birth in alignment and in a facilitatory way. The lower picture is showing the wide arc management of the bone Marshall technique. One condition is there, like if sometimes it may happen that a patient is coming to us with the breech, the chest anterior condition. She is with the stuck up of head. She came to us, and that situation where the chin is hinged behind the pubic symphysis, the chest is anterior. It is not. The back is posterior. In that situation, a Prague maneuver can be helpful. In Prague maneuver also, it is also similar to the Bone Marshall technique. We need to, with the wide arc, we need to keep the baby towards the mother's abdomen, so that the hinge of the chin should be defeated. Sometimes now the Prague maneuver is modified that the second hand can be held out with the pulling of the shoulder in the downwards direction to help out the baby. Chances of the perineal injuries are more with the Prague maneuver. So these are the pictures of the various maneuvers. One more thing is there, that when the easy delivery of head is not possible, the applications of the Piper's forceps, which is long bladed forceps specially designed for the breech delivery, can be done. The baby can be hanged upside, and the application of forceps from the below can be done, and baby can be taken out. Sometimes, as I have said, that if the patient is pushing with the not complete dilatation of the cervix and head is being stuck up, and especially in the premature breech where the smaller breech comes out but the head is comparatively larger, so it gets stuck up with the rim of the cervix. So in that certain situation, sometimes Duherson's incision, which is incision over the cervix, it should not be a very big incision. It should not be in the center at 12 o'clock because the extension can go up to the bladder. So small incisions at the 12 o'clock and 2 o'clock position can help it out. Breech extraction usually not done, only as a salvage procedure for the delivery of the second of the twin, which if it is in the breech or transverse. So in that only the groin traction is required and the Pinard's maneuver is required. The Pinard's maneuver is the same as the maneuver we have discussed, that flexion at the knee and shifting over of the leg by the external rotation. So this is the technique for that. Now, even with the assisted breech delivery, there may be some complications. There may be some maternal complications like increased frequency of operative vaginal delivery, like forceps, episiotomy extensions, etc. Increased frequency of the chances of the cesarean, anesthetic complications, trauma to the mother and the baby, and sepsis can happen. Fetal complications can be various, especially if the too much of maneuverability is there, like for head intracranial hemorrhage, neck fractures, for lung rupture. It is also very important when we hold the baby at the time of delivery. I will show the video later. I have not incorporated in the this PPT because of the technical reasons. So when we hold the baby, if we are not holding it from the pelvis, but holding it from at the abdomen, so even at the chest, it can cause lung rupture, it can cause splenic rupture, it can cause the kidney damage. So this is very important that how you need to handle the baby. Only at the bony prominences you can hold. Even the spinal cord injuries are common with the breech delivery. Brachial plexus injuries like Erb's palsies, Klumpke's palsies, and even the humerus and clavicular fracture. So with the technique, I will show that to where to give the pressure. Otherwise, it causes injury to the even the fetal bones. Even the femoral and hip joint femoral fracture and hip joint dislocation and hematoma can happen. So we all need to keep all these things also in mind whenever we are going for the assisted breech delivery. The third stage usually remains as usual as in other delivery, oxytocin to be given with the delivery of the head. The placenta is delivered in usual manner as in normal labor. So the art of vaginal birth is really a symphony, a wonder, a dance of joy, and a celebration of life. And it should be learned by all the obstetricians so that in cases of emergency and in cases of the planned vaginal birth, we are well versed with the techniques and become expert of them and can give joy to a mother. Thank you very much. Monica, madam, I
Yes,
have
ma'am.
a 5-minute video with the because of some technical issues. My own video I am not able to play, which I have made with Nagarya madam herself in detail. But this I have taken from the net. If it is allowed, I can share it for 5 minutes to just
Yeah.
show
Sure,
the
sure.
important points.
I think chairpersons will, Dr. Shabana is there, and please kindly go ahead. Yeah.
Thank you. So, are you able to see the video, madam?
Not yet. In fact, Abhi, there is nothing on the screen. Only.
Okay. Just 1 second. Is it there?
Yes, now we can see the video.
You can see the video.
Yeah.
Okay. So see, the first thing is hands off. The breech is by contraction itself, it is coming, and we are doing nothing, just patiently seeing. The perineum is stretching, and with each contraction, the buttocks are coming down. And it appears to be probably like we will come to know whether it is a frank breech or a flax breech after some part is coming. So no hurry, no haste to pull it out. We are waiting, and we can just support if needed to just keep our 2 fingers inside the groin to give it a direction, not to pull, to give it a direction to rotate the back anteriorly, तो ये गलती से भी back posteriorly ना जाए. So to give it, and while we are giving our fingers inside, our pressure should be towards the groin, not towards the femur. Otherwise it should never be towards the thighs. Otherwise it will cause the damage to the femurs. So just after that, once again we can push the perineum back and just can support. And if the legs are extended, we can help in flexing the knees. So flexion of the knee and lateral rotation at the hip joint keeps the leg coming out. Here also you can see the flexion at the knee and external rotation at the hip makes the leg coming out. And very easily, without any damage, it can come. When the chest and the trunk is coming out, we need to check about the umbilical cord. We need to check about the hands in the hollow of the sacrum. Here, this is antero-posterior situation of the shoulders are coming. And very easily in the posterior hollow, we can, this is the Losset maneuver. If the hands are extended like in this, so by Losset, the posterior one we have made anterior and it came out of the symphysis pubis. This is the Mauritius Melli wheat where once again with the wide arc with the support, the baby is like an asterisk kept on the head The occiput is pressed with the middle finger, and the two finger on the second hand presses the malar flexion. We should never keep our finger inside the mouth because it can cause the temporomandibular joint dislocation. So this point is important. Traction as well as flexion, anteriorly as well as posteriorly. Flexion from the both the sides. I'm sorry. If we are unable to deliver the head by this, either we can make a wide arc Burn-Marshall technique, or we can apply the Piper's forceps from below. Always remember from below. We can give episiotomy if required. We have already infiltrated. Your assistant should hold the baby higher so that you have the place. हमारे जान से कभी-कभी कोई लोग नीचे बैठ के भी forceps लगाया करते थे because we need to apply the forceps from the below. So putting the forceps blade inside in a usual manner as we put in a general forceps application, yes, definitely we have to see the cervix is fully dilated, no vaginal wall is coming. And see, one more important thing, when you are pulling down by the forceps, when you are pulling down the head by the forceps, see, from the one hand, we are preventing the pulling towards the anterior side. We are pulling only down, pressing by one hand and to pull it anteriorly. Otherwise, there will be extension and the pressure at the neck, and there may be injuries there. So to avoid that can be done. So thank you for allowing me to share this video. Though it is not mine because of some technical difficulty, a beautiful video which me and Nagaria madam has made years back. Something happened, so I could not show that. And this is about the assisted breech delivery. Thank you so much.
It's a very, very informative and very explicit video. And the dummy is also like a real baby only. I'm so fascinated by the dummies nowadays. They are becoming more and more real life nowadays. But we would love to see your actual video. To Dr. Jyoti, whenever you please manage to, download it, kindly please do share in this group. The Synergy 6, the group will be active. So thank you so much.
Thank you.
I think if Rachna ma'am and Shabana are there, they can give their concluding remarks. I think
Shabana ma'am has left, ma'am.
Okay, okay. So Dr.
I would
Jyoti,
like to have the concluding remark if Tripti Nagaria madam is there.
yes, yes. Tripti ma'am, would you like to speak a few words about the presentation by Dr. Jyoti Jaiswal? I think let me
Yes,
give the,
yes.
yeah, Tripti ma'am is there.
Yeah,
Yes,
Yes.
ma'am. She's there.
really, yes. She is very right to say that whatever she is saying and she had explained about the breech delivery is very important, and particularly so that actually whether you are delivering an assisted breech delivery, either the delivery of the head by yourself or with the help of the any kind of the forces. Technically, the point which should be kept in the mind is when you are going to give the traction, when you are making it pop, rolling it towards the abdomen, what is the direction of the Piper's forceps while you are pulling it down? Because every single step, if wrongly done, is going to harm the baby. And that is why when you were saying that the dummies are really very good, they are very helpful as well for teaching purposes. Just before going directly over the patient or to deliver the fetus, if they practice in this under supervision of the consultant or the professor or whoever is there, the senior person, they are actually learning the right thing, and then they will not be in fear when they are releasing the fetus. So every single moment should be seen carefully, should be learned carefully, and definitely once you have learned it, there is actually what had happened when we were the student. We have got the habit of delivering, but nowadays when the students they are growing up, सब बात में जो इतना डर लगता है कुछ हो गया तो what the law will say, they may stew. So, and of course, if really if anything happens, the fear comes out to be true. So before jumping down, Rami and the mannequins, they are really very helpful. And the video is really very nice. I'm happy to see all this. And yes, Jyoti is saying the right thing. We had already prepared one very nice video about the proper conduction of all the stuff. Assisted BGB, beach accession, everything is there. Maybe some problem might be there, so that we did not show it to you. But wow, wonderful, Jyoti. Very
Thank you, ma'am.
nicely explained, very nicely explained. Proud of you. So
Thank
thank
you,
you
ma'am.
so much. Thank
So
you.
thank you, Dr. Tripti, for the comments. And Dr. Jyoti, I just wanted to ask a quick question. This Piper's forceps is the normal outlet forceps, or is
No,
it
ma'am.
something different?
In long.
It's not a normal outlet forceps, though the normal outlet forceps can also be used in time of need. It is not absolutely contraindicated. But pipers are specially designed, the shanks are long. So the application becomes easy and pulling becomes easy. When we pull the baby by head, when it is in the cephalic presentation, nothing obstruction is in front of us. Directly we have to apply and pull. We can see everything. But in breech, after coming head of breech, where we need to put the forceps, the whole fetus is in front of us. So the long shanks for the better maneuverability is there. These are the having the thinner blades and longer shaft.
So I think what I remember is each forceps blade has got a cephalic curve and a pelvic curve.
Yes.
Those curves must be also very gentle so that the outward
Yes.
traction doesn't go.
Yes.
So thank you. Thank you so much, Dr. Jyoti. That talk was really brilliant. And now I would like to, invite Dr. Purva to start the second session.
Thank you, ma'am. Moving forward to our second session, that is on operative vaginal delivery tips and tricks. Sorry. I invite our chairpersons, Dr. Tripti Nagaria, ma'am. Madam is presently President ISOPAV Raipur Society. Dean
I think you have a bad cough. You want to?
Yes, ma'am.
Yeah.
May I,
Nandini, are you?
yes, ma'am. I'm
Neetu?
here.
Yes,
To
please.
chair this session, we have Dr. Tripti Nagaria, ma'am. She is president of ISOPAV Raipur chapter and also Dean CCM Government Medical College Durg. She is past state secretary of Association of Societies of OBGY in Chhattisgarh and also held many posts in the ISAR IMS Raipur branch. She has many publications to her bag and is also recipient of Global Signature Award and is invited faculty in many conferences. We are very honored to have you as chairperson, ma'am. Our next chairperson is Dr. Shashi Srivastava, ma'am. Because of some emergency, she will not be able to join us today for the webinar. Next chairperson is Dr. Ishrat Jubair, ma'am. She is currently treasurer of Bhopal chapter of ISOPAV. She is director in Unique Hospital Bhopal and very senior consultant at Bhopal. I welcome you, ma'am, to chair this session. I hand over the session to our chairpersons to introduce our speaker, Dr. Arup Maji, sir. He will be speaking on operative vaginal delivery. Tripti, ma'am, can you please?
For giving me this opportunity to introduce the teaching, Dr. Magister, actually, Magister needs no introduction at all, because he's a very and always help and always to teach, and that is the best
Dr. Neetu?
quality.
Yes, ma'am.
Dr. Tripti is there or not?
She is speaking. Actually, her network is unstable, I guess.
So may I do the honor?
Tripti, ma'am.
Yeah, please do go ahead. Go ahead, sister.
Her network is unstable, actually.
Yeah, go ahead, sister.
Yes, ma'am. Yes, ma'am. Dr. Ishra. Yes, ma'am. Yes,
Okay,
ma'am.
okay, thank you. Thank you, Dr. Neetu, for inviting me as a chairperson in this wonderful webinar. And it's my pleasure to introduce today's speaker, Professor Arup Kumar Majhi, sir. Sir is past president of ISOPAP, and presently he is a professor of Sangaini, Shanti Niketan Medical College, Boipur, West Bengal. Sir is author of Bedside Clinics in Obstetrics, Bedside Clinics in Gynecology, and Operative Obstetrics. Sir is a former professor and head of the department in Obs-Gynae department, RG Kar Medical College, Kolkata. He was editor-in-chief, Indian Journal of Perinatology and Reproductive Biology, 2010-2016. President, Bengal Obs-Gynae Society, 2016-17. President, Kolkata Chapter ISOPAP, 2018-20. 30 years of teaching experience and examiner of UG, PG, and DNB. He is a former national corresponding editor of Jogi. And sir has near 108 publications to his credit. We welcome you, sir, for enlighten us on very important topic of operative delivery tips and tricks. Welcome, sir.
Thank you everybody. Am I audible? Am I audible,
Yes,
Dr.
sir.
Monica?
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir, you're
Okay.
audible.
Okay, just I am sharing my slide, then I will start. Is it visible?
Yes, sir.
Full screen,
Okay.
please.
Yes.
Sir.
Okay. Good evening, everybody. At last, the birth has taken place. Dr. Monica, congratulations, because 1 year back, from the 1 year back, not the birth, not the crawling, not the walking, the baby has now running. And Monica Bhopal chapter of ISOPAP. Thank you, Dr. Monica.
Thank you.
And
Thank you.
also thank you for their young stars, actually. The today there's Neetu is there, Purva is there, Nandini is there, and your today's program, the Synergy Club by ISOPAP Bhopal chapter. And I'm very fortunate to see that you have assembled this year, the Raipur Obstetrics, Raipur ISOPAP chapter. Both the chapter, the Bhopal and Laitapur is with me. And the great Jyoti, that is the Tipti and Jyoti. Tipti and Jyoti as together, and there's so many academic achievements and presented. So when I was approached to talk about the operative vaginal delivery, instrumental vaginal delivery, so Neetu asked me, Madam, sir, what will you say? It is a dying art. I mean, not at all. It is not a dying art. I have still several presentations on dying art, but I want to convey the tips and tricks of all the technical details of all the things, so that the operative delivery can be applied by the junior brigade, because we, the teachers, are also going to forget to apply the to do the operative vaginal instrumental vaginal delivery. With this introduction, I am starting. Worldwide, the rate of cesarean section has increased, while instrument delivery have decreased. And many factors contributing to the instrument delivery alleged to be a lost start. But it is not a lost start, not a lost start, and not a lost start. We must have to learn more and more to apply more and more. The judicial use of the instrument can lower the expenses of obstetric care as well as the hazards related to the cesarean section present and future. Why operative vaginal delivery? What is the reason? Cesarean section in the second stage of labor significantly morbidity and implications of the future birth. Goal of operative vaginal delivery is to mimic the spontaneous vaginal delivery with minimum of maternal and neonatal morbidity. An advantage is that 78 to 90% of the chance of spontaneous vaginal delivery following a vaginal birth of the first pregnancy. And all complications, that is the major part of the problems of the cesarean section, all complications, the present and future pregnancy are avoided. Best can be achieved by the selection of the cases, gaining enough knowledge, skill, and experience of the operative vaginal delivery. Every obstetrician must know the tips and tricks of the techniques. I will try my best to detail as far as possible by without in the practical workshop or in a presentation with some small video also. Now, there are three types of devices of operative vaginal delivery. All of you know the obstetric forceps and ventouse, the vacuum extractor, and the Udon device not available in the practice till now. An Udon device that I have seen for last 5 years. Team Decoit, you know, came to Kolkata for 3 times to show the Udon device. And first just pre-COVID and another this year also in Royal College, All India AICC Royal College conference, this workshop. But till it is not available, probably it will be available and more safer than the present available gadgets. Now I'll start with the forceps delivery. Now forceps delivery is a procedure where the fetal hair is extracted vaginally by the device obstetric forceps, thereby helping the delivery of the fetus. In few circumstances, and this device can be used by the abdominal loop section, sometimes with the vectis, sometimes with the single blade. The history of landmark of the development of the obstetric procedure. All of you know the RG Kar Medical College is famous is now for another reason, but it is very famous. I was a professor and HOD from the 2013 and retired from there. And Professor Kedarnath Das collected so many large number of forceps, and he died during his work in 1936, and a good route to the good book. So I cannot start with my topics without remembering the Kedarnath Das. Before that, I said, see, the obstetric forceps are invented one of the Peter I and Peter II of the Chamberlain family, probably at around 16,000 AD. Everyone knows. And this was kept secret for 100 years or more and used for only the royal ladies. And in 1888, large number of Chamberlain instruments was discovered in a well-concealed chest in Woodland Mortimer Hall, Essex. These are those some of them. Sir Kedarnath Das designed a special type of forceps which is long but lighter, suitable for Indian babies. And many of these forceps have been kept in the forceps gallery and the article. Some of these forceps, I have the pictures of so many of the forceps of that is the separate lecture, separate presentation I have done, the history of evolution. The RG Kar Medical College, there are hundreds of different types of forceps he collected. And this is Sir Kedarnath Das, and he written a book in 1926, and with 878 illustrations, he collected from throughout the world of the different forceps of variety. The original Chamberlain forceps had only cephalic fur. Smelly introduced the English lock, and it was Leverett from Paris who introduced the pelvic curve in 1747, and Ternier, a Frenchman, developed axis traction mechanism in 1877. The different varieties of obstetrics. If you see the different varieties of the obstetrics, but in short, you can divide in the log curve obstetric forceps and short curve obstetric forceps. The modern version is the Wrigley's obstetric forceps. This is the 20th century obstetric forceps. And straight long obstetric forceps, that the Killian forceps, the rotational forceps, and the 19th, this is also 20th century, 1916, not so commonly used nowadays, but it is in some country. This is the long-term obstetric forceps. That is the original Kedarnath forceps. You can see here Kedarnath forceps. The fenestrated blade. Blade is fenestrated, parallel shanks, and English lock with fixation code. There are the configuration are different. And most simple forceps, I think, that is the Simpson's obstetric forceps. Very simple and fenestrated blade and lighter and parallel shanks and English lock. And there is the English lock. And this is another forceps. This is the Louis-Card obstetric forceps, the overlapping shank, pseudo fenestrated blades, and sliding and the sliding lock. And this is another forceps, that the Takar-McLean forceps, solid blade overlapping shank. You can see the in case of Das's forceps, that is the fenestrated blade, Simpson's forceps fenestrated blade, and Takar-McLean forceps is the solid blade. Both have advantage and disadvantage. And Leuchard forceps, there is a pseudo fenestrated blade. Advantage of the fenestrated blade is that is the good grip, but disadvantage is that there will be the maternal pelvic or trauma. But advantage of the Tucker McLean is that there is a slipping and there is no damage of the lateral pelvic wall. So that is why the compromising those things, that is the pseudo fenestrated blade, the Leuchard prosthetic blade has brought into the light. And short curve obstetric forceps, so Wrigley's forceps. This is the long curve obstetric forceps, Das's forceps, and this is the Keeland forceps, rotational forceps. Another forceps already Jyoti has described, that the Piper forceps. Probably Dr. Monica will ask, there is Piper forceps is the long forceps, and there is some curvature also, the perineal curvature. One is the curvature, so that the forceps, fetal head in the breech presentation can be extracted an easier way, so that the fetal head in breech, it should be in flexed condition always. Can be, but because if there is the extension, there will be larger diameter, it will be difficult to deliver. So this is the Piper forceps for arthroctomy head of the chest. Now parts of the forceps. You see, the parts of the forceps, actually the two halves, each half is called a branch. Each half is called a branch. This is the one half and this is the another half. These are the branch. And long curve obstetric forceps about 30 centimeter long. It is 15 inches. And the short and the Keeland forceps is much longer. Keeland forceps, the rotational forceps is much longer. And each branch consists of the blade. This is the blade. And another is the shank. This is the shank. And the lock. And this is the handle. And the fixation is not found in all forceps. Particularly the Simpson long forceps, this is not found. And axis traction division, this is the optional. It is not so used nowadays. And each blade is named as the right and left according to the relation to the maternal forceps. That is a slide on which it is applied. And forceps is left and right according to the blade. It is not to the handle, according to the blade. According to relation of the maternal of the side on which it is applied. So these are the parts of the forceps in short. Each blade has a toe, heel, and two cover. Toe, there is the toe, this is the toe, and this is the heel, junction of the blade and the shank, each blade. And English lock, which consists of a socket system, Das, Simpson, Tucker McLean. This is the English lock. And you see the sliding lock along with the shank, that the Leuchard, there is sliding lock. And another is the French lock. There is a pivot on the left blade which fits with the notch of the right one. And also the combined lock, German lock. But the common lock is the English lock and the sliding lock. And the two curvature. I think there is so many postgraduates here. There's a very confusing questions, and they always what they will answer. What is the cephalic curvature? What is the pelvic curvature? And the cephalic curvature, the answer will be is the curve on the flat surface which fits on the fetal head during the application. That is the concave part, and distance between the tips of the blade is only 1 inch, 2.5 centimeter, and wide jet gap in between the two articulated bays is the 9 centimeter. So, and the biparator diameter, we know average is the 9.4 centimeter. So there is some compression, but that is the physiological compression. And pelvic curve is one of the edge to the curve of the sacrum. Anatomical pelvic edge, and both the edges, not only the convex edge and the convex edge, that fits with the sacral curvature, and anatomical, that is the coincides with the anatomical pelvic curve of the keras. And the cephalic application, the forceps blades are applied on the side of the blade by which the biparator diameter lies in the widest gap between the two blades. This application is safe for the baby, and our purpose will be to the cephalic application. Otherwise, the baby will be damaged. And pelvic application is this type of application. The blades are introduced by the side of the pelvis, ignoring the position and occupying by the fetal head. This should always be avoided. This should always be avoided when there is there is malrotation of the head. And so cephalic application and pelvic application of the forceps, correct application is that when there is complete rotation of the head, that is direct occiputo anterior, the cephalic and pelvic application correspond, and it is the ideal method of the application. If there is no rotation, we'll have to rotate by manual or by the forceps itself. Then you apply so that the cephalic and the pelvic application correspond. Axis traction mechanism. This is the mechanism by which axis traction device is applied in mid forceps operation, and it helps to apply traction in the correct axis of the pelvis, and less force is needed to deliver the fetal head. And when you apply the axis traction, your purpose will be so the axis traction rod that is will be parallel with the shank of the pelvis, shank of the blade, shank of the forceps, so that you need not do how will you give traction and think of that about the traction. Just you make the parallel, and that will be very easier to deliver. Now, functions of the obstetric forceps. One is the traction, that is the main. By traction, the head is delivered. Second is the protection. To some extent, the fetal is protected out of other than the ventus, the fetal head is protected by the fetal head. Particularly the premature baby, it is contraindicated. Ventus is contraindicated, but forceps can be given with protection. And compression, physiological compression to some extent. And the rotation. Sometimes with the forceps, even the low forceps, you can give the rotate after applying cephalic application, you rotate and then you give traction direct occiputo anterior. And also by the rotational forceps like Killand forceps and Barton forceps, you can give the rotational forceps. Used as the vectis to assist the delivery of the fetus in cesarean section. Now, the indications of the operative behavior, definitely the fetal indication and the maternal indication, where there is the fetal distress, cord collapse after coming head of the breech, and mento anterior phase, and phase to pelvis delivery, and maternal prolonged second stage in spite of oxidation. And sometimes the cut short the second stage of labor, here there is the second stage of labor. So there the patient mother is in distress condition, lying eclampsia, severe preeclampsia, heart disease, and posterior pregnancy. This is the undergraduate teaching, and the combined indication. The classification. This is the classification is actually the old classification, but something to see. The important thing is the classification ECAG 2020 is the outlet forceps. Outlet forceps is nothing but fetal scalp visible without separating the labia. It is done mostly, the outlet forceps is done. And fetal skull has reached the pelvic floor. Fetal head is at or the perineum. But in outlet forceps also, you will see the head is in the perineum, that there is no rotation. So head is occiputo anterior or occiputo posterior, or head is right or left occiputo anterior or occiputo posterior, and rotation does not exceed the 45 degrees. And so that is the very important thing. And low forceps, leading point of the skull is at station +2 centimeter on the pelvic floor, and that is a 2 subdivision. Rotation of the 45 degree or less is required. Rotation of more than 45 degrees are required. And mid forceps, the fetal station is between the 0 to +2 centimeter, and high forceps is not given and abandoned. And these classifications of the operative delivery, operative vaginal delivery, is applicable for both forceps and both ventus. So these are the picture of the low forceps and the mid forceps. Remember, the mid forceps station is between 0 to +2 centimeter and low forceps +2 centimeter or more, not on the pelvic floor. That is the outlet forceps. Now, contraindications of the forceps application: incompletely dilated cervix, definitely will not give. There is a chance of cervical tear, and floating head, and obstructed labor due to contracted pelvis, and some malpresentation. Cannot give the brow presentation, mento posterior face. The presequoids, it is also the undergegular treatment, but something we will have to add. This is the head engaged, presentation vertic, and fetal position known. Fetal position known. That is not the direct occiputo anterior. Known suspected CPD. known fetal weight estimation, membranes rupture, cervical loss fully dilated, bladder empty, no fetal coagulopathy, demyelination of the fetal disorder absent. But one thing is the experienced operator and good anesthesia, pudendal block, and also can be done in the epidural. And counseling and informed consent is very important, and that we will have to counsel, take the informed consent, and all the things are documented in the TICI, the VHT, what we have done, the operative procedure, these are these, but that will save us and increase, will help to increase the number of forceps delivery. Now, basic steps. The basic steps are simple thing. Determination of the side of the forceps blade first, and better to articulate, then you determine introduction of the blades, left blade first, followed by the right blade, the locking of the blades and the screw fixed, and the traction. There's the traction. There may not be screw in all cases, and the traction is given. And pull and delivery. This is the basic steps of the forceps delivery. Patient in lithotomy position, antiseptic dressing, draking, and dripping, and catheterization to make the bladder empty, internal examination to ascertain about the fulfillment of the condition, episiotomy with local infiltration of the lignocaine or pudendal block, and whether routine episiotomy is given. This is the controversy. Usually in forceps, about 80 to 90% episiotomy is needed, and ventus less number of episiotomy is needed. And when the head is come down, then it is given. Now, determination of the side of the forceps. The blades are articulated in front of the maternal pelvis. The cephalic curve, that is the cephalic curve, are facing each other. Convex cephalic curve looking forward and pointing the tip of the blade, pointing the tip of the blades upward. Tip is the toe is the upward, and convexity forwards. The blades corresponding to the left half, the maternal pelvis is the left blade, and on the right side is the right blade. And it is very easier to learn if you take the forceps. The postgraduates I am saying, take the forceps and articulate. Side determination is not a matter of difficulty. Introduction of the left part, that is important. But in some cases, the right blade is needed. But normally the introduction of the left blade is whether the direct occipital anterior, the 4 fingers of the right hand are introduced into the left posterior. It is not directly the lateral wall, slightly posterior. You will see this is the application. You see what will you do? This is the left blade. This is the left blade. 4 fingers have you introduced. 4 fingers introduced, and the blade is the forceps is parallel to the right ligament. This is the left blade, parallel to the handle of the left hand is held between the thumb and the 2 fingers of the hand. Thumb, always practice the thumb and 2 fingers of the hand. 2 fingers of the hand. It is not like this, that is the goal. And keeping parallel to the right ligament. You can see your point. And next important thing is the pressure. How we give the force. Right thumb is placed between the heel and the blade, and most force is given the right thumb. You think the most force is given by the right thumb, but not by the left from here. But what is done there? Blade is pushed by the left hand with passive movement and with the less force. That is the most important. You just see. This is the photo is done recently. The video has been done. I will show how it is done. And then the left blade is held by the assistant. You ask the assistant to hold like this. Left blade is given, left blade is pushed. Assistant will hold it just like this. Next you come, the right blade is introduced. The same manner. In the same manner, 4 finger and left thumb and a maximum pressure given by the left thumb, but not by the right here also parallel to the left inguinal ligament. And that is the basic steps actually. And the students should learn that, postgraduates or younger learn that. Now locking of the blade is done, and you can see the locking of the blades and fixation of the screw, traction in low forceps, first downwards and backwards in low forceps. Outlet forceps is straight down or horizontally down. and then straight horizontally, and finally upwards and forward toward the mother's abdomen. Finally upwards toward the mother abdomen. And this is the traction is given. You can see the first is the downwards and backwards. Next is the intermittent and steady pull are given preferably during uterine contraction. You give during uterine contraction, not in between contraction. That will help the deliver the baby easily during uterine contraction. If required, you can give also the oxytocin at that time. And the first downwards and backwards, and then straight horizontally you can see. Then after the straight horizontally, when the subocciput comes under the symphysis pubis, then you can finally upwards and forward toward the mother's abdomen. That is delivered. And now the head is delivered. You can see the head is delivered. And the fixation screw is released. If there is a fixation screw, the blades are removed. Right one first, followed by the left one. The delivery completed. And as usually, the active management of the third stage is given. The retained unit oxytocin immediately within 1 minute, and then the delayed cord clamping is the rule, MTSL. And following removal of the placenta, cervix and vaginal walls are inspected. You always inspect the cervix with the 2 sponge holding forceps after giving the forceps delivery, all operative vaginal delivery. Episiotomy and any other tears, if present, are repaired. Now, position low, rotation not completed. This is another, because in the definition, the classification used to, there may be the 45 degree less or the slight 45 degree more. So what will you do that? This is, I have taken this picture with the fetus pelvis. You can see that maybe the head is left occiputo anterior. And so what will you do? You cannot give the directly applied the pelvic application. You do the cephalic application, and anticlockwise rotated 45 degree to make it occiputo anterior. Then the cephalic application and pelvic application correspond, and then traction is given. This is also true for the outlet forceps also sometimes. Application in the same way, but it is easier. Instead of 4 fingers, only 2 fingers are given. First pull is not needed here. And this is the directions of the full and various types of the forceps operation. I am not going into detail of this. This is my picture is my in book. I have summarized the whole thing, the what traction will give in which type of forceps. In occiputo posterior position, that the face to pubis delivery. One thing is for the postgraduates, you must know the mechanism of the face to pubis. What is mechanism is the root of the nose hinges under the symphysis pubis. So what should be the traction? Traction will be the horizontal and backward, so that the root of the root of the nose comes under the symphysis pubis. Then upwards and forwards, the that is the head it will be delivered, and after that by downward traction the face is delivered. So this is the mechanism, the 3 steps in the face to pubis delivery. And in face presentation, what is happened in presentation, instead of occipital root of the nose, the submentum hinges under the pubis, so already extended. So nothing is to done. We will have to bring the submentum under the symphysis pubis, and you will have to deliver by flexion, downwards and traction. The chin appears under the symphysis pubis, and then upward movement, the upward movement show that the face and the total head is delivered. Now forceps in after coming head of the bridge, it has been clearly and very minutely described. Jyoti, Dr. Jyoti has very clearly described it. Long curved forceps or forceps are used, and even that these forceps are also used, long curved forceps. You take the long forceps because Piper forceps is not available on this. Trunk of the basis is lifted by the assistant. Very easy. The forceps blades are applied. The pull is giving along the pelvis. And you will have to maintain the flexion of the weight, because the diameter here is the suboccipital frontal, and forceps in the so this is the pectis. This is another is the pectis in the cesarean section. This is the severe section. I am sorry, there is a submentobregmatic diameter in case of head. In case of freeze delivery, it's the submentobregmatic actually. And the vectis in the cesarean section. Vectis in the cesarean section. This instrument can be used for the head, the floating head, particularly in case of floating head during the cesarean section. And now video for the lower forceps operation I will show. You just follow the video. Now the identification of the side and locking checked. The patient in lithotomy position, anticipating dressing, dipping done, and catheterization is done. Catheterization is done. Catheterization. Then we'll examine again, re-examine whether the criteria has been fulfilled or not. Particularly the position of the head, we'll have to see, and the descent and the position. And I will now see. Now look at this picture. Very that how it is the right parallel to the right angular ligament, and the forefinger is introduced and moved toward the posteriorly, and by the right thumb it is moved thumb, and by the left thumb only the passive movement, not look with that, but with the right thumb easily go. If there is a rotation, there will be easily go. And then the lead blade is applied. Lead blade is applied. The similar with taking a lubricant. Usually the sterilized liquid paraffin is taken. Liquid paraffin lubricant, and by using, and then the locking is done. The locking is done. The locking is done, and fixation is the fixed, and then to start the traction. And better to give the episiotomy after some the thumb of the baby head comes below. The episiotomy is given in the meantime. Already the infiltration has been done. You do the infiltration before, so that there will be save the time, and then traction, give the traction. Then traction, as I have said, in low forceps operation, downwards and backwards. See. And try to, and for the juniors, and try to avoid there's too much of jerky movement. You just straight forward. There's a jerky movement sideways. Try to avoid this. Too much of, and then during contraction, only during contraction, you give the traction as soon as the head is delivered. Head is delivered. The fixation screw is loose. Fixation screw, and the rest part is the there is also the anterior shoulder comes under the simplex pubis. Comes under the simplex pubis. There is a cord around the leg, passes off, and the head is delivered by the posterior shoulder. The both shoulders are delivered, and so other areas to know, I am not going into detail. The prophylactic forceps, it giving, anticipating the prophylactic forceps, anticipating the complications of the mother and fetus. And trial of operative delivery is an important thing. And failed forceps, that the failure of the delivery by the forceps, it may be failure to apply and failure to one is the that is the locking, and third is the failure to deliver the baby. Manual, their main cause is the defect in the defect in our choosing the cases and selection of the cases, and malrotation of the forceps delivery or the postgraduate some idea. Rotational forceps. It is a tentative attempt to expedite the phase with forceps application in the case of doubtful mid-pelvic context, and OBD is supported by the ACOG. But once that attempt should only be done if successful or likely to occur as judged by the clinical assessment. And vacuum now takes to the vacuum assisted operative delivery. Ventouse or vacuum extracted suction access delivery do deliver the fetal head by creating negative pressure between the instrument and the scalp of the fetus in liver. And there, James Young Simpson, not only the 1954, but it was Young Simpson attempted about 100 years back of the milestone in 1849. And Sweden in 1954, the modern ventouse was invented with the metallic cup. And early vacuum extractor used by the Simpson, made by the natural rubber in 1849. This is the picture I have taken from the old Mondokar operative, which is in my stock, actually 1970, 9th edition. That is only the rubber. What is the failure? So 100 ETRs are not used. Basic component of the ventouse: suction cup, shaft, handle and connective tube, and vacuum generator. And this is the old we used to do at the younger days. When the RMO registered, I used to do this. That is the metallic cup and the bicycle hand pump, and this is the vacuum system. But now it has been changed. It's the food patel with the food we use in our institution use. I have seen the Raipur also. There the small ventouse is very beautiful ventouse also Raipur. That is the used by the knob. The pressure is created here. They created here the pedal, but here the pressure is created only by the knob. And this is the three types of cup: metallic or soft, metallic, and this is the recent metallic cup, and this is the silicone cups. Different sizes: 40, 50, and 60 meter. It may be the 55 or 65 is like that. And according to the company, they have marketed here. And depth is usually the 2 millimeters. The soft cup and silicone cup is commonly used. Less scalp injury than metal cup, more failure than the metal. And soft cup, pliable bell-shaped cup, meaty soft bell cup, and the rigid cup, rigid type of firm flattened cup with a circular ridge around the cup. The QQ, if you know, this is the pump. This is not so popular in India. Actually, pump. By pump only the pressure is created, and in some institution this is used in cesarean section head delivery. Pump, rigid mushroom cup. And the manometer, you can see there is a two types of manometer. One is the clock manometer and one is the digital manometer. Clock manometer and the digital manometer. The kg per square centimeter or millimeter of the mercury. So you know, must have to know the conversion. Conversion of the kg per square centimeter and the millimeter of mercury. The indications of the ventouse: delay in the second stage. In case of incomplete rotation, the occiputo-posterior or occiputo-transverse position, trial of ventouse instead of the trial of forceps. And second baby of the twin, sometimes high up. The vertex presentation, there is delay in descent and head is in high position. And contraindication: fresh presentation and after coming head cannot be given. Premature baby, there is the chance of the intracranial hemorrhage less than 34 weeks. And in acute fetal distress, if the immediate delivery is needed, the forceps is better. If the forceps can be given, definitely. Suspected fetal coagulation disorder. And my advice is giving is, if you want to give the ventouse delivery, you see if there is a mild contraction. Also, if there is a pelvic contraction to some extent, the ventouse will failure. There will be failure of the ventouse. Chance of failure. Prerequisite should be in the second stage, almost in full salvation. Sometimes small dream, there may be small dream that is dilated during the delivery. There should be no pelvic contraction and vertex presentation. Ensure fetal position and station before application. Head should be in low down position in single told pregnancy. And patient and empty the maternal bladder, and anesthesia, local infiltration, pudendal block, and also the epidural. The counseling, consent, and documentation is very important, both the cases of the operative vaginal delivery. Application of the suction cup, basic step, creation of the chignon, and final negative pressure, and delivery of the head by traction. And the proper size of the suction case is seen. You can see, I'll show the video also, small video, and all the instruments are assembled and airtight. All the instruments, proper size is. A patient is in lithotomy position, Episiotomy following perineal infiltration of protegum with 1% lignocaine is not mandatory in all cases. After perineal retraction, you can see that after perineal retraction, the two finger, the suction cup is introduced sideways inside the vagina and placed over the fetal head, more toward the axilla. It is on the flexion point. So what is the flexion point? The to place on the cup over the flexion point, it is the 3 centimeter in front of the posterior fontanelle and 6 centimeter behind the anterior fontanelle. What is the advantage? It is when the traction is giving, there is a minimum diameter will come out and the head is flexed and there is asyncretism also corrected, less traction is needed or the flexion point. The concept of flexion point is very good. After placement, cup circumference is palpated to exclude maternal soft tissue entrapment to avoid injury and pop-up. And always you do after creation, after application, and also the chignon formation, so whether the maternal soft tissue inside between the scalp and the fetal head. A negative pressure is first created 2.2 kg per square centimeter, slowly for 2 minutes. Thereafter, the pressure is gradually raised 1.1 kg per square centimeter or is equal to the 76 millimeter OEG, whatever is written there in the digital or usually digital is usually the millimeter of Hg, and the clock there may be both types of unit are there, and the time needed is produce effective vacuum is 6 to 8 minutes. However, the pressure may be increased rapidly. It is now proved by the RCOG guideline that the ICOG Gintop guideline, the radiatic pressure application for vacuum is recommended. Rapid, you can raise the pressure rapid, not 1 minute, 1 minute, 1 minute like that. So this is the checked. This is the maximum 600 millimeter is usually needed. A pull is given intermittently during each contraction, and it should be at right angle. That is very important. A right angle to the plane of the cup, and with the simultaneous placement of the other hand inside the vagina. You check inside the vagina in the left hand finger. Inside the vagina, you check whether there is any soft tissue in between the cup and the fetal head, and also there is the detachment. When there is a chance of detachment, you wait. And the cup separation can also be detected within the vaginal sphincter. Head is gradually delivered with auto rotation of the head with the traction. This is the picture you see. What is the surgeon? You will give traction with the right angle with the cup and left finger inside the vagina, vagina, and also the assistant will give the perineum pressure to the perineum to maintain the flexion of the head. Do not attempt to rotate the fetal head or use rocking movement. Both is a rocking movement, both in case of ventouse and also the forceps. Maximum suction pressure should not exceed 600 millimeter. Consider lowering suction levels between contractions and always give the traction during the contraction. And usually 3 to 4 tractions and not more than 30 minutes are needed, average 15 minutes. As the head comes out, negative pressure is released and cup removed. So this is the chignon. You can see the chignon that is vanishes with the 12 to 14 to 24 hours chignon. And active management of the third stage you will do routinely. 10 units oxytocin immediately and delayed cord clamping. And placenta is delivered by controlled contraction. Here is the controlled contraction. If there is no descent of the fetal head with successive 4 traction and within 30 minutes, the procedure discarded in favor of either forceps or cesarean section. However, the sequential use of the instrument is not recommended except in some cases where cesarean section could not be done because the chance of the high perinatal morbidity and mortality. Sequential instrument, usually ventouse followed by the forceps operation. And complications, maternal and fetal, you can see maternal complications, the forceps delivery, episiotomy is given, needed more, and valvovaginal tear, more in the forceps, oasis, more in the forceps, postpartum hemorrhage, urinary bladder incontinence is equal, and the cephalhematoma, more in the vacuum, and subgaleal hemorrhage, more in the vacuum, retinal hemorrhage vacuum, but intracranial hemorrhage, it has been found is almost equal to the vacuum and the forceps. Facial or scalp depression equal, and jaundice and hypervolemia, vacuum and forceps equal. Facial nerve pulse is definitely more in the forceps, and cervical spine injury, mainly keel and rotational forceps, rare. Skull fracture mainly by the forceps, rare. So now you see the video. And it is done by my colleague, Dr. Professor Obhijit Rokhi, on my direction. And Professor Obhijit Rokhi is also my colleague and Arjikar Medical College. Been taken to see the tested, the negative pressure is tested, and you choosing the right size. Don't take the very small. You see the pressure is increasing by testing, and then the antiseptic draping, patient in lithotomy position, antiseptic draping, and catheterization is done, and the prerequisites, is examined prerequisite, and searching for the posterior fontanelle, the flexion point, and before giving the episiotomy, the lignocation infiltration is given. Introduction of the suction cup sideways. You can see this is to learn. The sideways you keep, and sideways the keep, and more towards the occiput, on the flexion point. And the checking whether the maternal soft tissue in between the cup and the maternal head, the scalp. And now the negative pressure is created. First signon is created. And then tested by giving traction, gradually increase the pressure, and always the shaft of the ventus is right angle to the cup. That is, and traction is giving, gradually the traction is giving. And here, when the head is low down, the episiotomy is given. It is not mandatory, and the patient obstetric the episiotomy. All of you know. Left hand inside the vagina. Two things. One is the search for any soft tissue again, and also whether the cup is being detached. It's a practical experience. Sometimes if the cup is detached, you wait. And then you see the head is coming out gradually. The pressure is released. As the head comes out, the pressure is gradually released. Baby is delivered. And here is also there is a cord around the neck. It is not so uncommon cord around the neck. Actually, the delayed second stage of labor, cord around the neck is and again the active management of the third stage. The oxytocin 10 units IM immediately and delayed cord clamping. The placenta is delivered by the control contractions. So instrumental vaginal bath should be considered for prolonged second stage when the safety criteria has been fulfilled. However, without gaining the level of the experience, it is dangerous in the hands of an experienced or hasty obstetrician. And that is my suggestion today to all of you advice. From tomorrow onwards, who do not do a vaginal delivery, operative will do from residency program should be available with school with the skill operator to teach the procedure by simulation. What is been seen beautifully the breech delivery by Dr. Jyoti and Dr. Tipti. So conclusion today, operative delivery has definite role in the patient obstetrics, and careful use of both the ventouse and the forceps will minimize the fetal and maternal injuries. Ventouse is associated with less maternal injury. Regular training is essential for the registrars and residents accustomed with ventouse delivery. Avoid to switch over from vacuum to forceps or vice versa due to increased neonatal mortality. My acknowledgement to Professor Rokit, and all the photographs are from the book. Thank you for your patience hearing. Thank you giving me the scope.
Thank you so much, sir. And that was a very deliberate. Your lecture was very nice and deliberate on the instrumental delivery. I would like to request Dr. Ishrat Zubair, ma'am, if she is there.
Yes, Neetu, I'm here.
To conclude
Yeah,
the session.
sir, it was really mesmerizing. Your videos was like I went into my residency's day. Nowadays, although we are more in the haste in doing cesarean section, resident level, or even at the private practice level, but sometimes we got caught in few patients. We really need that we should be master in these techniques, applying properly forceps and applying vacuum properly. Sometimes it is definitely needed. So, sir, it was one more eye opener again, and it is encouraging also that we could again we can avoid unnecessary cesareans by mastering these arts. Thank you, sir. It was a wonderful lecture. Thank you.
Thank you so much, Maji sir. It was a very, like Ishrat said, mesmerizing lecture, which brought us back many memories. So I think I am from that generation of gynecologists. I started PG in 1994, finished in 97. So those 3 years, I saw the transition from the teachers, the old time teachers to the new time teachers. So these old time teachers, they taught us the art. And sir, I started private practice in a very busy city area of Bhopal with lower middle class and middle class population. And so many cesareans I could avoid just because of operative vaginal delivery. So I was a little confident because my husband is a pediatrician. So I thought, he was standing, I applied low outlet forceps, and even I applied mid cavity, sir. I applied innumerable ventouse, but it is magic in properly selected cases, sir. And teachers like you will always keep the torch burning. Thank you so much.
Actually, the public has the very afraid of the forceps delivery. So my advice is to keep a good ventouse instrument in every obstetric unit, and it is very safe actually. If you can apply in the very good ventouse, that is the airtightness. That is the airtightness is very important factor, and that will be very. I think Dr. Tripti is here, Dr. Jyoti is here. I have seen how they are efficient to do everything. I have.
Good evening. Really mesmerizing, very wonderful talk. And same to Ishrat, I'm feeling that we have went into our residency days. One more utility of the ventouse added in the floating head during cesarean section. That is also work very beautifully. And instead of fiddling here and there and difficulties and delayed and out and going into the fetal distress later on during the delivery of head in cesarean, ventouse helps a lot in the floating cesarean case. And nowadays a pandemic like situation is coming for the PAS spectrum because of the so high increased number of the cesarean section. So 50 to 60% of the cesarean deliveries even we are having in the government setups, sir. Because of one previous section is a majority time, it is an indication. So whenever the primary cesarean section is being taken, these things can help out in decreasing the operative, the abdominal delivery in comparison to the vaginal one, and they are really helping a lot. So nothing good on both the sides, but a balance is really required, and these kind of teachings definitely help each and everyone to make this balance.
I have shown you some the metallic cup, that is a newly designed metallic cup. that cup is actually used for the cesarean section, and not,
Yes.
not the and cesarean section you have the mentioned that cup is very good for the using in the cesarean section.
Yes, sir.
And that cup, I have shown the 3 types of cup. One is the old metallic cup, a new metallic cup, and the nylon cup. The middle one is very
Beautiful presentation, sir.
Thank you
After
so much.
such a beautiful presentation, I
Sir.
was also taken back to my residency days when
Right,
Professor
right.
Gangadhar Sahu sir has taught me about the instrumental delivery. And I remember that Ventue's vacuum was first time brought to our hospital, and we were taught how to apply the vacuum. Now we are running short of time, so we will quickly move ahead to the next session. For the next session, we have panel discussion on
Thank you.
antenatal fetal.
Thank you all.
Thank you.
Thank you all for giving
Thank
me
you.
the
Just a minute before winding it this particular session, I must congratulate sir. आपने बहुत सारी यादें ताजा करा दी. जैसे मैडम कह रही थी 94 से 96 we were in from 86 to 89 and we had a large number of the forceps and vacuum at that time. इसमें सीजर बहुत कम हुआ करते थे, vaginal deliveries ही ज्यादा होती थी, and every kind of obstetric was done at that time. अभी तो सिर्फ 2 ही होते हैं, या तो कुछ vaginal और बाकी सब सीजर. So we have done everything, internal podalic version, decapitation and whatnot. So very nice, sir. Thank you so much.
The
Thank you so
youngster,
much.
Dr. Neetu, Dr. Purva, Dr. Nandini.
Indeed,
Thank you
sir.
all. And
We need
you
to
try
learn this art,
try
sir.
to promote the instrument.
Right.
Yes, yes. Indeed, sir.
Thank you, sir.
Is Rachna Dubey, ma'am? Any question?
I think Rachna ma'am, I'm calling. She is not receiving the call. Let us
Okay, ma'am.
see. So Neetu,
Okay.
Nandini, please start the panel
Yes,
discussion.
Dr. Nandini,
Yes,
please
ma'am. Yes,
take over
ma'am.
the session.
Yes, ma'am. Good evening to one and all. Now moving ahead with our panel discussion on the very important topic of antenatal fetal surveillance. To moderate the panel, I would like to invite none other than Dr. Sneha Bover ma'am, who needs no further introduction, but I would like to have the pleasure to introduce her. Sneha Bover ma'am is the medical chairperson of, is elected chairperson of Medical Disorders Committee, and Madam has received various awards such as International MS Signature Award for Phenomenal Leadership in 2020. She has received the SN Malhotra International Award for their outstanding work in her rural obstetrics, Surusha Award for her community service national and national award, the Anandbai Joshi Award. Madam has also been a founder president of Vidarbha ISOPAS. She has also been the certified SPI National Adolescent Trainer, and she is a peer reviewer of Jogi. She has published more than 30 chapters and articles in national publications. We welcome you, ma'am. It's an honor to have you here.
Thank you.
Our expert panelist is Dr. Ruchi Gupta, ma'am. Madam is professor at the Pandit Jawaharlal Nehru Medical College. She is the alumnus of a very prestigious institute of PHU Varanasi. It's an honor to have you, ma'am, Ruchi Gupta, ma'am. Now introducing our panelists from all over India. Dr. Geeta Agarwal, madam. Madam is a consultant in Heritage Hospital, Raipur. She is a laparoscopic surgeon. Moving to our next panelist, Dr. Nisha Vati, madam. Madam is a assistant professor in the Pandit Jawaharlal Nehru Medical College, Raipur. Dr. Pallavi Singh, madam. Madam is an associate professor in Gandhi Medical College, Bhopal. She has a teaching experience of more than 1 decade. Dr. Shalini Agarwal, madam. Madam is director and consultant at Saubhagya Mother and Child Care Hospital. She is also the secretary of Raipur Menopause Society. And currently she is assistant. Our next panelist is Dr. Sneha Goenka, madam. Madam is the assistant professor in Chirayu Medical College, Bhopal. Our next panelist is Dr. Surdeep Porwal, madam. Madam is currently an associate professor in NGA Medical College, Indore. She has a teaching experience of more than 1 decade. Our next panelist is Dr. Sushita Srivastava Madam. Madam is Associate Professor in RKM CHRC and she has many publications in national and international journals. Swati Deshwari Madam, it's an apology, Madam could not join. Madam is the consultant in the Nidan Clinic and she's a very well-known obstetrician. Moving with our next panelist, Dr. Shweta Agarwal Madam. Madam is the director at Ashoka IVF Center and she's also the founder member of Chhattisgarh ISAR. We welcome you, ma'am. I request Madam to go ahead with the panel discussion.
Thank you, Dr. Nandini, for the generous introduction, I would say. Thank you so much, Monica and her team, Nandini, Purva, and of course, Neetu. Without much ado, I would like to share my screen and I hope all of you can see it is full screen. So can we have the videos on for all our panelists, please? I think, yeah, Pallavi, Surabhi, Shweta, yes. Hello, everybody.
Hello, ma'am.
Yeah. So please don't mind, my voice will be a little cranky in between. I'm running a viral fever at present. So friends, all of you know that we are on a ISOPA program and it's not only maternal health, but the perinatology as well. So hearty congratulations, Monica, for selecting this topic for panel discussion. I think very rarely done that. And today we are going to discuss the fetal surveillance, which will be antepartum as well as intrapartum. So my first question to Dr. Geeta. Do we have Dr. Geeta here?
Yes, ma'am. I'm here.
Why do we need to monitor the fetus? We are monitoring the mother by doing all the examination. Why do we need to monitor the fetus? And what are our goals for fetal surveillance?
Madam, we need to monitor the fetus as we want to know whether the fetus is growing as per the gestational age, whether there's a risk factor with the fetus or the mother, which can hamper the fetus growth. And we want the fetus to deliver at term without any complication and with the neurological injuries. So finally, the goals of the fetal surveillance are we want to reduce the fetal morbidity and mortality, the any neurological injury to the fetus.
Yeah, that comes in morbidity we are covering.
Yes.
So perfect. You have bang on this, that you want to basically, triage which fetus is high risk and which one is low risk. And for the high risk fetus, you want to offer the various modalities of monitoring as far as the growth and well-being is concerned. And for the ones which are not high risk, the routine monitoring or routine antenatal care should be good enough. And we want to avoid the unwarranted, unnecessary interventions or investigation. So definitely our goal is to deliver the healthy baby and from a healthy mother, right? So, Dr. Nisha, how do we assess the fetal well-being antenatally? Right from clinical part, I would say clinically first, because we have to go to the basics first and then the gadgets. Dr. Nisha, please.
Yes, ma'am. Clinically, we from the early gestation, we can assess bimanually by doing a PV examination, and this is from the first trimester, and with the ultrasonography, we can assess the fetal viability, and also in the second trimester onwards, we can do anomaly scan, and we are doing quadruple marker in the second trimester, and from the third trimester, from the 24 weeks, we can assess clinically from symphysiofundal height from the 24 weeks onward. It is corresponding with the gestational age. Basically, the symphysiofundal height correspond with the gestational age from 24 weeks onwards. And by counting
right. But before going to the internal examination directly, right from the general examination, do we get some information that things are going on well?
Yes, ma'am. Before on the first visit, we are doing the patient's weight at the first antenatal visit during the first trimester, and with the subsequent visit we are taking the weight of the patient, how much she is gaining weight during her entire journey of the antenatal period. And from the 24 weeks we are assessing the symphysiofundal height clinically and the abdominal gut also. And along with
Trying
that,
to
we are
locate the fetal heart sounds.
fetal heart sound, yes, ma'am. And we explain the patient for the fetal movement count daily
Yeah.
by the Cardiff method.
Go to the details later on. On ultrasound, what you want to see when you want to assess the growth and well-being?
Actually, ma'am, by the ultrasonography, we are monitoring the some parameters like abdominal girth, head circumference, female length, and yes, and bipyramidal diameter. By that, we are getting the fetal
We
weight.
won't say abdominal girth to this, we'll say abdominal circumference, right?
Yes,
FC.
abdominal circumference. Yeah, SC and AC ratio is a more important because in case of FGR, it is increasing. And also, we are looking for the grading of the placenta and amniotic fluid volume and other Doppler parameters that includes the uterine artery Doppler, umbilical artery blood flow, middle cerebral artery blood flow, and if patient is before 32 weeks to decide the mode of treatment plan, we look for the ductus venosus also.
Right. So I know, I agree to you that, nowadays every pregnancy is pressure and you want to assess and monitor the fetus right from the beginning. Yes. Anybody said something? Somebody wants to add? So what are the every pregnancy is precious, but then we are not going to provide all the investigations for every. So what are the indications for fetal surveillance we can from the maternal or fetal point of view? Dr. Pallavi.
Yes, good evening, everyone. Like Madam said, we cannot screen closely every pregnancy, so we have to be restricted to all high-risk pregnancies. So all high-risk pregnancies, the fetal surveillance is to be done. So I'll categorize the indication for fetal surveillance in 3 major heads. The first is the maternal indications. So the whole spectrum of hypertensive disorders of pregnancy, we need to screen, especially the preeclampsias. And then we have a diabetes associated with pregnancy, whether it is a gestational diabetes or a pre-gestational, both needs to be fetal screening to be done in all cases, whether even if it is controlled. Then we have an RH immunization, immunized pregnancy. We have a mothers with renal disease in which especially the serum creatinine is going more than 1.4. Then we have thyroid disorders with uncontrolled thyroid results. Then we have hemoglobinopathies in the mother, like the sickle cell disease. Then there is an systemic lupus erythematosus disease in which we need to screen because there is an effect in the placenta. Then the post-IVF pregnancies also, they need to fetal surveillance closely, especially after 36 weeks. The pregnancy, the mothers who are having age more than 35 years, they also need close fetal surveillance. And if the mother is having obesity, like the pre-pregnancy BMI is more than 35 or like near 50, this fetus is also to be screened. And under special mention on the patient who have a history of previous stillbirths or a previous bad obstetric outcome in form of previous FGR baby or a severe previous history of severe preeclampsia, we needed to deliver the preterm labor or preterm delivery. That is to be. So these are all the special like main maternal indications. Now we'll come to the fetal indication. The first of the foremost fetal indication is the fetal growth restriction. Then we have multiple pregnancy. When the mother is perceiving less fetal movement, that also makes an indication for close fetal surveillance and any fetal anomalies. Then we have placental indications also. An isolated oligohydramnios is also counted, and the polyhydramnios. Then we have chronic abruptio placentis, in which there is a small abruption for a long time. We need to monitor any abnormal insertion of the placenta, filamentation, and all that, abnormal insertion of the cord. Then, if the fetus is having a single umbilical artery. So these are the few fetal in rare, but the few fetal.
So abnormal placentation and even the abnormalities of the amniotic fluid, that needs to be, on your priority list. So
Yes.
basically, as you have already talked about the past history of adverse outcome, I would ask Dr. Swati. I think Dr. Swati has not joined. Maybe you can continue on this. If you have a past history of adverse outcome, severity of maternal and fetal indications, basically you have to intensify the surveillance, right? So generally, the monitoring is recommended when the estimated fetal maturity is sufficient. Why are we monitoring? As you said, right from the beginning, yes, you have to do this fetal surveillance because you want to tell the patient and the relatives that everything is normal and it's going on well. But when you want to actually survey this fetus, you want to make sure that this baby will survive if outside the uterus if you remove this fetus. Okay, so monitoring is recommended when the estimated fetal maturity is sufficient enough to expect a reasonable chance of survival should intervention be necessary, right? So what are the clinical parameters? I would like to go to the next panelist now. What are the clinical, Dr. Shalini? Dr. Shalini, do we have Dr. Shalini?
Dr. Shalini messaged that due to some emergency, she just left.
Okay, okay.
Mentioned that she had some acute emergency.
Okay, Jyoti, thank you so much. So I think Dr. Sneha, you can have this clinical parameters for, monitoring the growth and well-being.
Ma'am, clinical parameters for monitoring the fetus would include the maternal weight gain is one parameter by which we will assess whether the fetus is growing or not. Secondly, we can also check the fetus growth by monitoring the symphysiofundal height, and it should correspond to the week of pregnancy. And the abdominal girth is also used to assess the growth of the fetus, especially in the last trimester. And the Likert volume can also be assessed clinically. If there's less Likert, the mother might complain of decreased fetal movement. And polyhydramnios can also be checked for clinically.
Okay.
Yeah.
So as you have said, symphysiofundal height, abdominal girth, etc. But as you rightly said, the maternal weight gain, So along with this, definitely checking the blood pressure or yourself personally going for the urine dip,
Urine dipstick
test or maybe urine examination as a routine, which add value to your clinical examination, definitely, because that can predict you that this patient may land up into some or the other complication. So how do you count the fetal movements?
Hello.
Yes.
Good evening, all of you.
Yeah.
Counting of fetal movement is very important. While we are counseling the patient, it may be done by two methods like Cardiff count of 10 formula or by daily fetal movement count.
Right.
The Cardiff count of 10 formula, we can counsel patients to count fetal movement starting from the morning, say 8 or 9 a.m. and comes to the end as soon as the 10 movements are perceived by the mother. And it is instructed to report to a physician if mother perceives less than 10 movements during 12 hours in 2 subsequent or no movement is perceived.
Yeah, so you have, said various ways are there to, know that the fetus is well in utero, and, you are talking so much about fetal movement. What does the evidence say? Do you really feel that, counting?
Randomized control trials said there is no improvement in fetal outcome by daily fetal movement count in age group or control group. If we are taking mother who is doing daily fetal movement count in age group and control group is the mothers who are not doing daily fetal movement.
Yeah, but this takes us to another discussion that, what are the factors that affect the maternal perception of fetal movements, even though
there are several factors like like this, if the fetal is fetal sleep-wake cycles, if mother is consuming some drugs like narcotics, if mother is obese, there is excess cycle like mother is having polyhydramnios, if mother is chronic smoker, and if fetus is having any CNS abnormality. So in all this condition,
Right.
mother can
So
have
what message we want to give here is just don't get carried away by the fact that, research says that, our data doesn't support, that fetal movement count indication that the fetus is well in utero. But in fact, there can be some other factors that, hinder the perception of the fetal movement by the mother. Okay. So I think clinically this is the best and most cost effective measure we have, that, we know that the fetus is well in uterus. Dr. Ruchi, do we want to add something to this discussion? I can see
Yes,
Dr. Ruchi.
I wanted to say, I wanted to add some points. One thing is that counting the movements for 12 hours, it is sometimes very cumbersome. And the
Yes.
patient is a bit anxious every time counting the movement. So
Yeah.
it is a very good point that we can say that if she is perceiving 3 movements in an
Yes,
hour,
yes, that is what
that
we
is
are
sufficient
in
enough.
fact promoting, that, it is absolutely not practicable. So perception of 3 movements in 30 minutes, that is the third line you can read here. Correct. Regarding the evidence, do you want to add something? That is what I wanted to ask you. The comment I have already made, that don't get carried away by the evidence, that the evidence doesn't support. So don't stop counting the fetal movement and don't stop asking the mother. In fact, continue, because that is the most cost effective way of knowing that the fetus is well in uterus. There may be some other factors which hinders the perception, as somebody has said that, yeah, sleep wake cycles, will come to it, and there are certain placental factors and even the amniotic fluid factors, the sedative drugs, as you have already talked about. So what information do you get on ultrasonography? I think Dr. Geeta, you can take up this. Geeta and Nandini, I can say. Nandini, can you please put on your video?
Yes, ma'am.
Yeah, please. So, can you please comment on this? What parameters or what information you gather from ultrasound? Though we are saying that fetal well-being, yeah, later, maybe second trimester onwards, third trimester, but what is the importance of the basic dating scan?
Ma'am, the dating scan can make us know when will be the expected date of delivery.
Yes.
It can
Yes.
help in the growth monitoring of the fetus also, and to actually determine the date when the periods were irregular in a patient. It will
Right.
help.
Yeah. And of course, the other things, number and well-being, and of course, the anti-scan and the various soft markers. Correct.
Yes.
So that gives you the information during early pregnancy. Target scan, definitely you will try to rule out the other anomalies. Now we come to fetal monitoring on ultrasound. So Dr. Surabhi, we want to know from you how to monitor the fetal well-being on ultrasound.
Ultrasound is a very important and non-invasive tool to monitor the growth of the fetus and the well-being throughout the pregnancy. And by ultrasound, we can diagnose a fetal well-being from the early trimester to the last trimester, as you already discussed earlier. In the second and third trimester, we can serially monitor biparietal diameter, femur length, head circumference, abdominal circumference, and amniotic fluid volume. If pregnancy is normal, then head circumference to abdominal circumference ratio will be less than 1 or equal to 1. If it is more than 1 beyond 34 weeks, or it signifies the fetal growth restriction. And if biparietal diameter beyond 34 weeks is less than 1.7 mm per week, it also signifies fetal growth restriction. Umbilical artery, Doppler velocimetry, and venous Dopplers are very important. We can calculate various parameters by Doppler studies like SD ratio and pulsatility index and RI ratio, the resistance index, and they guide us about
I would like to ask you a single question. On ultrasound 4D color Doppler, what is the single most important indicator that compels you to terminate the pregnancy or go for intervention?
Ductus venosus velocity. It shows reversal of flow then
Yeah.
immediate delivery will be
Yes, so whether it is absence or reversal, that is still a matter of debate. Naturally, as a clinician, see, when we say absence, it has already comes to a standstill, right? And in this scenario, maybe the brain, because though there is brain sparing, there can be some sort of hypoxia there. But because the evidence says it is reversible, we have to theoretical say, but it is absent and reversal of the end diastolic flow. That is an indication that we can no more wait for this. Any other addition anybody wants to do?
See, I want to add something that this absent or reversal,
What is
it matters.
A-wave? Yeah.
The absent or reversal of the flow in the umbilical artery, it basically decides for the delivery in cases of the IUGRs, which are less than 37 weeks or 36 weeks. But
Right.
more than 36 weeks, even if there is brain sparing, we should not wait to the absent or reversal. We should deliver that moment only. Because brain sparing is a decisive factor there in the late onset IUGR.
That is what I said. It is a matter of debate whether we should wait for that. Okay, that is what we said, that even though the evidence says so, as a clinician, we are the better judge. As it is, the baby is not going to deliver on its own. By the time we wait for this, it may be, little late. And that is how it's in what is called as informed decision making. You have to talk to the patient and the relatives. You have to tell them the pros and cons of both the sides. And then, of course, you have to help them taking the informed decision making. So that is about the ultrasound. What is the role of non-stressors, Dr. Sushruta? Do we have Dr. Sushruta?
Yes, ma'am. Good evening, ma'am.
Yes, good evening. Please.
Non-stress test or cardiotocography. Actually, this is a very good method of fetal surveillance monitoring. And in this, we put a probe on the abdomen, as we all know, and we trace the fetal heart rate. We check the fetal heart rate for at least minimum 20 minutes.
Right.
And in that 20 minutes, we check for the baseline fetal heart rate, then beat to beat variability of that fetal heart rate, whether there are accelerations or not, whether there are decelerations or not, any different kinds of pattern like sinusoidal pattern present. So all these things that are the basic things, they will definitely gives us a good note that whether the fetus is doing well or not.
Yes. So we go one by one, that you do the tracing for 20 minutes. You make the patient lie down on left lateral position. You mark the fetal heart. You try that external transducer. You make it on. And you said that you have to take the observe for 20 minutes. Now, how many movements should we have? How much acceleration should be there? What is the reactivity? Please explain to the audience.
Ma'am, for to say that this NST test is reactive, at least we have minimum 2 acceleration in the period of 20 minutes. And it should be around...
If I'm allowed to interfere, she should feel or pursue at least 2 movements. That is mandatory.
2 movements, and these movements should be associated with the accelerations.
Correct.
Accelerations, and the amplitude of accelerations should be minimum 2.
Yeah, 2 movements, there should be an acceleration. So how much should be the acceleration? 15?
Yes, ma'am, that I'm coming on that. It is around 5 to 15 beats and lasting for at least 15 seconds. The acceleration should be more than...
Yeah, 15 beats per minute lasting for 15 seconds.
15 seconds.
You should have 2 such acceleration. Right. So suppose now this patient of yours, everything is fine. She's, you are just trying to observe her and monitor her. During this period, she did not pursue any movement, 20 minutes. What is your interpretation?
Ma'am, as we have already discussed, there are many things, and like sleep pattern is also there.
Yeah.
So we should extend the NST for another 20 minutes also. We can also ask the patient to take some glucose or something. I mean, sometimes because of hypoglycemia also their movements are affected.
Yeah.
And if she is lying straight, we can try this left lateral position. if it is done in supine position. So we can do all this maneuver before declaring that it is a non-reactive NST.
Yes. So first and foremost, most important is the sleep-wake cycle of the fetus. So you extend the NST for another 20 minutes or maybe maximum 45 minutes. And then to this, you can watch the acceleration. Mother under sedative or drugs, as we have already said, some of the women are, they are really negligent, reluctant to observe, and that's the reason you have to specially train them, give them a probe to mark, tell them that if you perceive like this, you mark it, and to this, what is the acceleration we have to see. So this is very, very important, not to miss on all these things. So suppose, how do you say that the variability is good or less? How the pattern, baseline pattern, how do you discuss that?
Ma'am, the variability is like around 3 to 5 beats per minute. It should be changing with every beats. If it is more, then it means it may give some. If the beat to beat variability is less, then it may give the indication that there is some hypoxic injury going on, or some hypoxic insult is going on to the fetus.
Okay. Dr. Shweta, do you want to add anything to this discussion?
Ma'am, besides after variability, sometimes we also have to see the deceleration.
Yes. Yeah, that she said, spontaneous acceleration or deceleration, whether they are there.
Yes.
But to the movement, if she has acceleration or deceleration, yes. So these are the normal variations. What you must have bit to bit variability to make, to say that fetus is doing well inside the uterus. And then, as we have said, that to two movements, the baby should have at least two acceleration of 15 beats per minute, lasting for 15 seconds. And we have already talked about the fallacies of these tests. Interpretation is very, very important. As you know that, there is lots of debate going on that because of this test and because of this investigation, there are a lot of unnecessary cesarean section. So that also you have to keep it in mind, because you have to know what exactly the fallacies are. So these are the high risk and low risk pregnancies we have already talked about. Now, what is the indication for continuous electronic fetal monitoring? Now we will go to labor and we talk about what are the maternal and fetal indications for continuous electronic fetal monitoring. Dr. Swati?
Ma'am, she is not there actually.
Okay, so I think Dr. Shweta, you can continue on this.
Yeah. Ma'am, for the continuous electronic fetal monitoring, the main indication is the maternal high risk factors and fetal high risk factor. Because generally it is seen that if there is a low risk pregnancy, we can go with that intermittent auscultation pattern, because that is good for a low risk pregnancy. But if we are feeling anything is high risk in the pregnancy with the fetus or the mother, it's better to go for a continuous fetal monitoring. Ma'am, you are muted, ma'am.
Neha, madam, where the panelists are not available, even we can take the insights from Dr. Ruchi on those points.
Yeah, we are already taking, no? We can, I think, Dr. Ruchi?
Yes, madam.
Yeah,
See,
we,
it has already been discussed that continuous electronic fetal monitoring is required basically in the conditions where we are thinking that it is a high risk pregnancy, like all the cases of hypertensive disorder of pregnancy, diabetic mothers, VBAC trial, that is trial for 2 lakh, then mother is having either heart disease or any other disease, like where we are suspecting that she may land up into trouble, like if she is having APH or the Likert is reduced, FGR fetuses. So these all are the conditions where we need to have a continuous electronic fetal monitoring.
Also in cases of meconium stained Likert, and if the mother is requesting that I want continuous fetal monitoring, in that cases also.
Wherever you have deviation from natural, Dr. Ruchi has talked about the indication, and some, I think Dr. Shruti has already talked about maternal, fetal, and the pregnancy related indications for the monitoring. But here, when you are doing induction or augmentation of labor, In addition to high-risk pregnancies and the high-risk fetus, yes, before for at least 20 minutes after administration of prostaglandins and epidural analgesia also. These are the additional indications till now to what we were discussing till now. So we have already discussed and all of you know this. This is just to complete the presentation, baseline heartbeats and beat-to-beat variability and what are the different patterns. I'm sure all of you know this, so I'm going to skip this. Only thing is, what is the what all do you know about the scalp pH? Is anybody doing that? What are the advantages and what are the disadvantages? I think we have Dr. Surabhi, we can see you, and Dr. Geeta, anybody from you, please talk about this.
Ma'am, in our institute, we are not using doing start field, so I'm not just I have just knowledge of it. I have practically not seen.
Right. Anybody wants to say, Dr. Ruchi? You want to see? We are in fact we are taking expert comments from Dr. Ruchi. So once all the panelists have contributed, we would like to have from you, Dr. Ruchi.
Actually, madam, I have also not seen this internal fetal heartbeat monitoring, but I have an idea that whenever the NST is suspicious, then in that particular condition, definitely we can go with fetal scalp pH, which will
Yes.
give us a decision for delivery.
Right. Now, the only disadvantage is this: you cannot do antepartum because once, even when you are, you cannot do this antepartum because you need to have at least 2 centimeter cervical dilatation. You have to actually rupture the membranes, right? Apply this electrode to the scalp, and that is why these are the little, technical problems, I would say. So, but then nobody has the experience, but yes, such gadgets are available and people are doing it routinely. So, because we don't have it available, then we will not discuss it much. So, what are the different types of deceleration and what is the significance? Dr. Shweta, we would like to hear from you.
Ma'am, different type of decelerations. We have early decelerations, late deceleration, variable deceleration. Sometimes in cases like in abruption, we can see prolonged deceleration and sinusoidal patterns. So in early deceleration, it is usually seen in when the patient, when the fetus is trying to
What is
negotiate through
early?
the.
You just explain what is early. Yeah.
That is gradual decrease in the fetal heart rate, which is coinciding with the uterine contraction. The peak of uterine contraction is coinciding with the trough or nadir of the deceleration. That is the early deceleration. It is usually seen with the uterine contraction. And late deceleration, it is a little pathological, and here it is seen when the uterine contraction have ended. Then there is then there is deceleration. Then there is decrease in the heartbeat, heart rate of the fetus, lasting for more than 30 seconds. The nadir is coinciding after the uterine contraction has ended. The peak of the uterine contraction does not coincide with the trough of the deceleration in late deceleration. And variable deceleration, we have abrupt increase, rapid increase and rapid fall lasting for less than 15 seconds. That is variable deceleration. That is we can see in cases of occlusion of cord
compression.
Yes.
Yeah. So if you have a mirror image like picture, like the onset, peak, and the end is coinciding with the beginning of deceleration and nadir, and it is like this. So if it is a mirror image, exactly coinciding, that is early. What is the significance?
Usually, when the fetal head is trying to negotiate through the birth canal, when the compression of the fetal head, then we can see the early deceleration.
This is very important because it is what is called as inevitable fetal head compression, and that is why you get this second stage bradycardia. Some people call it clinically, and hurriedly people go for cesarean section, and this is one of the most blamed one, early deceleration. The moment you give them head low position, you just try to avoid the fetal head compression. Maybe you give atropine or buscopan, whatever it is, it comes back to normal. And late deceleration, that is the most important idea about the fetal hypoxia. Yes, Dr. Nisha, you want to add something?
Yes, ma'am. It is a given idea about the fetal hypoxia and cord compression. If cord compression, your uteroplacental insufficiency is there, we get the late deceleration in that conditions.
Right. So what is the cause for late deceleration?
Placental insufficiency.
Yes.
And fetal acidemia.
Fetal hypoxia, fetal
Fetal
acidemia. Right. So, as we have already talked about variable deceleration, it is suggestive of cord compression. Dr. Geeta, what are the typical and atypical presentations for this?
Ma'am, typical deceleration are one which have, shouldering. When the heart rate drops, the variability is maintained. And when it comes back to the baseline fetal heart rate. So the typical one. And atypical one, the shouldering is absent. And then there's W-shaped pattern on the fetal heart rate. The variability is not maintained, it is gone. And when the heart rate comes up, it will not come up to the baseline. So that's the atypical thing.
Yes, sinusoidal pattern, I'm sure all of you have seen it. I have already projected also. What does it indicate? What is the significance of sinusoidal pattern? Yeah.
Fetal anemia.
Yes, yes. Anybody can take up.
Ma'am, it indicates fetal anemia.
Dr. Sneha, we want to hear from you. Yes.
Ma'am, it indicates fetal anemia. Sinusoidal pattern is an ominous pattern, and it indicates fetal anemia. It is a sign where we need to expedite delivery as soon as possible.
Yes. So fetal anemia, it can be because of anything. It can be as you know that mother is severely anemic, then the baby can be RH isoimmunization, or maybe because of feto-maternal hemorrhage or twin-to-twin transfusion. The most important for us is the severe hypoxia. Yes.
The pattern shows reduced variability. The variability is very less.
Right. So we
It is
should
a
give it.
sinus
Okay,
link.
Isha, this is the normal I have mentioned already. Now, suppose the fetus, if it is a non-reassuring pattern, what will you do? Yes.
Ma'am, if it is a non-reassuring fetus, then I will increase the fetal heart rate monitoring, as well as I will provide the oxygenation. If a patient is on labor, I will provide the oxygenation to the mother. I will change the position of the mother. I will give her left lateral position. And if I have started oxytocin, then I will stop that drug and again reassess the patient after 30 minutes.
Meanwhile, you will continuously monitor.
Yes, continuous monitoring is ongoing there. Yes.
Okay. So this is what we have. We have the chart of baseline variability, deceleration, and acceleration. In reassuring, naturally everything has to be normal. The baseline heart rate 110 to 160, more than 5 beats per minute. That is the variability. No deceleration and acceleration should be present. What is the feature of the non-reassuring pattern? When do you call it as non-reassuring or abnormal?
When there is one non-reassuring pattern and two reassuring patterns.
When the baseline fetal heart rate is between 100 to 110, or if the baseline fetal heart rate is between 160 to 180, if the variability is less than
low
5,
or too high, yes.
If the variability is less than 5 for 40 to 90 minutes, and if there are any typical decel
Here again,
present,
very low or very high, like less than 5 or more than 40.
more than 25, and if there are any typical variable decelerations or one prolonged deceleration less than 3 minutes.
Okay. And when do you label it as abnormal?
When there are two reassured, abnormal is when the heart rate is less than 100 or more than 180, or if there is a sinusoidal pattern, if there's any variable, if the variability is less than 5 for more than 90 minutes, or if there are any late decelerations or atypical decelerations lasting for 30 minutes, or if there's any prolonged deceleration for more than 3 minutes.
So if you have all this, then you have to take further action, as we have already mentioned here: fetal scalp sampling or Alice scalp stimulation, vibroacoustic stimulation, and digital scalp stimulation. We do not have these facilities, but I think some of the medical colleges do have. So if at all anybody has the experience, can you please share with us?
No.
No. So I think we need to skip this. Can somebody talk about the standardized ABCD approach for a fetal heart, continuous electronic fetal heart monitoring? Hello? You can just have a look, Dr. Sneha. Do we have Dr. Ruchi? So this is actually, yeah. This is a standardized pattern. This is, can anybody talk about this? How do you go for, I see once you have a standardized ABCD approach, if at all you have a non-reassuring fetal heart, yes, anybody wants to speak
Ma'am,
about?
if it's a low risk pregnancy, then we need to monitor every 30 minutes in first stage of labor and 15 minutes in the second stage of labor.
If
The heart rate?
No, 1 second. If it's a
There is
low
fetal
pregnancy, you
Low
monitor
risk
Till
every 30 minutes for the low risk pregnancy during first stage.
first stage.
15 minutes for the high risk pregnancy during first stage.
First stage. Yes,
Okay.
ma'am.
Yeah. Second stage, how do you monitor?
Every 15 minutes for first stage, second stage for low risk pregnancy, and 5 minutes every 5 minutes for a high risk pregnancy in
Yes,
second
5
stage.
minutes. Sometimes maybe even following every contraction.
Contraction.
Yes.
Yes.
Okay. Okay. So this is how you have to confirm the FHR and uterine activity, and then you have to categorize what category it belongs to. 1 or 2 category is presence of moderate variability. It's not a problem. 2 or 3, whether the patient is low risk or high risk, that you have to decide. For a routine surveillance, first and second stage, as you have already talked about, and for high risk, 15 minutes for the high risk, second stage, as we have already said, 15 minutes for low risk, and 5 minutes of following every contraction for the high risk patient, right? So if at all you have this abnormality in the fetal monitoring patterns, if it is non-reassuring, then you have to plan for you have to expedite the delivery by various methods available, that you have to, of course, decide individually what is her inducibility, what is her presentation, and all those things. So this we have already talked about, that these are the different types of pattern, and this is actually the, it is a fetal scalp sample collection device with the help of which you can, that you actually prick the scalp and you collect the blood. So we don't have these facilities, so we will not discuss much about this. Only ST rise in fetus responding to, what is the significance of this? ST, negative ST elevation. If you give a stress to this fetus, yes, there should be ST elevation. If the fetus fails to respond to this, that means there is no ST elevation, then this is a fetus which is unable to respond. Yes, so this is a hypoxic compromised fetus. So friends, to conclude, for low risk pregnancy, simple clinical parameters like maternal weight gain, symphysis height, and abdominal girth, DFMC, auscultation of fetal heart sounds along with ultrasound, and of course periodic ultrasound, as we have already said, in the form of serial cephalometry, HCS ratio. These are good enough. Antenatal period along with intermittent auscultation of fetal heart with portable Doppler every 30 minutes during labor, as we have already said, for low risk, and 15 minutes during second stage. But for high risk patient, continuous electronic fetal monitoring is preferred. But if intermittent, then we should do it every 15 minutes, not to miss, and we have to keep the record. So every 15 minutes during first stage and every 5 minutes during second stage, if at all you want to go for intermittent monitoring for a high risk woman. Fetal scalp electrode should be preferred, which is more accurate but requires partial dilatation of the cervix and rupture of membranes, as I have already talked about. Ancillary tests are not required, and they are not helpful also. Fetal scalp pH, though approved by FDA, it is not recommended by SCOG. Fetal scalp pH and scalp lactate, there's not much of difference and it is not recommended. Use of ST waveform analysis for compromised acidotic fetus is not recommended at present. So I think we are still on the routine clinical monitoring, and whatever gadgets we have is ultrasonography, especially the 4D color Doppler, and of course the NST, non-stress test. I think continuous electronic fetal monitoring for high-risk patient. That is the that at the most we can have the luxury of that. Yeah, with this I think and I think that should be able to make us deliver a healthy baby from a healthy mother. So with this I stop the screen, and I would like to invite the comments from the expert Dr. Ruchi once again. I can see Gangadhar Sahu sir also still here listening to us. So sir can add value to this presentation.
It was a very elaborate presentation, madam. You have prepared very nicely.
Thank you. Thank you so much. And your comments have definitely added value to it. So
Thank you, madam.
Thank you. Thank you so much.
Madam
So,
is
ma'am,
Sneha ma'am is one of the greatest obstetric teachers, and her panels are famous all over the India. Yes, ma'am. So I think there's no topic under the sun which she cannot speak on. Only she gives me permission, Monica. Whenever there is some infertility thing, she tells me, Monica, you do it.
Yes, even though I am a trained infertilologist, I
Yeah.
don't practice, and I
Yes.
prefer not to speak on the subject in which I am not expert.
So,
So
but ma'am, your obstetric panels are just out of the world. They are really, really very good. So thank you so much, ma'am. And that brings us to the end of this extensive webinar. We have just crossed 3 hours. We are just about 3 hours, 10 minutes when we started. Thank you so much, dear speakers, Dr. Jyoti and Dr. Maji sir. Thank you, Gangadhar Sahu sir, for being there all the time. Thank you, dear panelists. You all were awesome. Thank you, Sneha ma'am. Thank you, expert Ruchi ma'am. And thank you to our support team headed by Dr. Vishal Dave, who's always there to give us the best webinars possible. And we meet with Synergy 7 on a very, very fantastic topic in the first week of January. Thank you so much. And have a great night. Thank
thank
you.
you, everybody. Yeah, I
Bye,
would
ma'am.
like to convey my regards
Thank
to
you, Monica. Thank you,
Narayan
Dr.
sir.
Monica, for excellent topics and excellent
Thank you,
CME
Maji
today
sir.
webinar.
Maji sir, your
Very
videos,
useful,
everything.
actually. Very.
Arup sir, good evening. Namaste.
Good evening.
I was there throughout your talk and I was listening to it. Definitely, I've made some comments also. So the videos were fantastic, sir. You are a great teacher.
Thank you.
And we are waiting for
Thank you.
Dr.
We continue.
real
Dr.
life
Monica.
video on breach.
Yeah,
We are waiting for Jyoti's video on breach.
Jyotia.
Yeah.
Definitely, I will make those problems go one side and take those videos back. And really, thank you, Monica Madam, because the exams are nearby. The postgraduates exams are nearby. They are in the month of January, and these all topics were important for them for the exam point of view as well. So all my students are attending this webinar. So thanks for the classes from the experts, Sneha Madam and Maji sir. And this is really very useful for them.
Thank you so much. And if ISOPAP permits, then I have a very nice idea for New Year. So we can do alternative birthing position webinar. Dr. Poonam Sharma,
that
Dr.
is also
Bangal
very-
sir are doing phenomenal work in this field. And recently we have got the TOT training done in GMC Bhopal. So alternative ABP could be one of the topics which could be clubbed with ISOPAP activities because it is an integral part.
It's a need of the hour,
vision of
Monica. The concept is changing, no? Birthing positions, even water birthing and all those.
Yes,
So
ma'am.
it will be great.
So there was one patient para one who delivered on a chair today in front of me, and once she held the baby to her chest after being delivered in front of a midwife, she was smiling and she was saying that this has happened to me like magic. I cannot believe that I have undergone labor. Thank you so much. With that note, we end this webinar.
Thank you.
Food for thought.
Can I say a few words?
Yes, sir.
Monica,
Definitely, Sahu, sir. Please go ahead.
I am waiting from the very beginning to the end, and as a surprise entry to your webinar. So first, since Sneha requested for my comments, I have no comments actually. I will say few things. One is very brief. I think, in my opinion, mother is the best fetal monitor. That everybody can agree with me.
Yes.
Second, the person who monitors, that counts. So a person should have patience, should have knowledge about the systems or the instruments used for monitoring, and he or she should have knowledge to interpret properly. Underline the word interpret. So your interpretation depends on the outcome of that pregnancy. Therefore, these three things are the take-home message as regards the fetal monitoring is concerned. So then I will come to Jyoti. So I have the experience starting from 1976 to 79 as a postgraduate, and then onwards till my retirement in a rural medical college, the VSS Medical College, Burla, 2012. Then in IMS in some hospital. So therefore, more than 40 years of experience in obstetric practice. So in the preparation heading, I will say that the most important preparation for breech delivery should be the preparation of the obstetrician who is going to conduct it. So he should have knowledge, he should have skill, and moreover, it should be under the supervision of an expert. And I doubt if any HODs, professors today are conducting the normal, vaginal deliveries, forceps instrumental deliveries, or breech deliveries and demonstrating those things to their students. So that is my first comment. Frank breech, is it a boon or bane? So frank breech, no doubt it is a good dilator. It helps in the progress of the breech labor, but because both the limbs act as a splint and both the ankles, the feet, are at below the chin, so the head remains extended throughout the pregnancy. Therefore, chances of extended head to come across during breech delivery, which has progressed so much, so it may create problems that should be kept in mind. Not in all cases, frank breech is the best thing. It is always a flexed breech. And as you said, Jyoti, masterly inactivity, that at that time our teachers were telling, in the books it was written, that masterly inactivity is the key word in breech delivery.
Yes.
So you are telling that episiotomy is optional. But in our time, we are taught that episiotomy is the first step for breech delivery. Why? Because it straightens the birth canal for easy descent of the breech. Second, because during any manipulation you have during breech delivery, you do not know. So therefore, you will be taking time to inject the, anesthesia, local anesthesia, and incising it, then going for manipulation. So it is hell of a time. So therefore, that is the first step. Second, again, you tie your hands. You read, you gossip, you talk with your boyfriend, girlfriend, whatever it may be in the labor room. Then allow the breech to deliver up to the umbilicus cord. Then you feel for the cord and try to draw the loop of the cord. And underline, Jyoti, note the time at that point. Noting the time at that point is the most important step that should not be forgotten, because we have got 10 minutes to deliver rest of the part of the breech. That is step number 2. Then again tie your hands. Allow the breech to be delivered till the lower angle of the scapula is delivered. Then you feel for the arms. If they are flexed, okay. If not, then comes your different assisted deliveries, and Lovset is the best, not the classical method. Again, you tie your hands till the nape of the neck hairline is visible, and Burns-Marshall technique is included under as a normal breech delivery. So that is not an assisted vaginal delivery. Burns-Marshall technique is a method that is under your spontaneous breech delivery. So these are the things, and these are the 4 cardinal points. At one step, you have discussed that Pinard's maneuver, that you popliteal fossa, you just push it, then the ankle will come down. So it is just a theoretical thing. There is no space at that time. All the liquors are drained. Uterus is cramping the fetus. How much you push, press the popliteal fossa, tons and tons of pressure, the leg, there is no space that the leg will come. That is the practical thing. So therefore, it is not a routine. So, Jyoti, it is a nice presentation.
Thank you, sir.
What I told, it is from my experience. So therefore, I can say that whether I am right or wrong, I do not know. We are being taught, we have been teaching, even Nitu can say that we are teaching, holding their hands. You cannot remember one thing, that breech delivery, there is a quotation. The quotation is, anybody, any obstetrician who can deliver a primary breech successfully, he or she should get a certificate that he has known obstetrics and he will pass obstetrics. Unless he or she does that, he will fail in obstetrics. So that is about this. Then Professor Majid, it is a beautiful thing. And operative vaginal delivery section, I have nothing to comment on that. But one thing I say, that the trainers are gradually disappearing. The trained obstetricians is an extinct, I can say, species going to be. So therefore, unless the trainers are there, you cannot find good trainees who can come and serve the society. Therefore, we, the senior people, should have take the pain to train the next generation, postgraduates or residents, so that they should be trained properly. So thank you, Nitu, for inviting me specially. I may be a rather ectopic audience or participant in this session, but I have learned a lot from these discussions. Thanks, Monica Madam, once again. Wish you all the best in future. Raipur chapter and hardcore isoporbian sitting in front of me, Jyoti. So I have lot of expectations from your chapter. I am remaining silent till now. So once I explore, so then you can know. So hopefully you will continue with that spirit. And Bhopal chapter, expectations is a lot more, not that these webinars, but in practical fields, your society should, hopefully your society is registered. If not, do it as early as possible to be a registered society and do activities which will help the patients, the need. Go to the periphery. My teacher, Sindhu Nadin Tripathi, tells me her slogan was, think rural and go rural. So please do such activities which will help the need. My slogan is walk the talk. So we do not need any advertisements. Our work will say what we are doing. Thank you very much. Once again, pray Lord Jagannath to bless you all. I have taken much of your time, so I beg apology for that. Thank you.
Thank you, sir. Sir, we are blessed to have you, and you are the pacemaker of today's program. You are not ectopic, you are the pacemaker. You have given us pace and direction. And sir, we are a registered society. My girls have worked very hard. We are totally registered. We all have got the life membership number now. So thank you for your blessing.
One of my students was a panelist. That she is Gita. So Gita, she is remaining silent. I don't know why she has, I think, broken the communication with me. So anything has happened, I don't know.
No, sir, I'm there.
Okay, thank you.
Thank you,
Sir.
Jyoti Sahu sir,
Namaskar.
for adding valuable points. And as you said that currently the teachers and the professor and heads are training the students or not. So my HOD has trained me in breech vaginal delivery, and I'm training my students in breech vaginal delivery till today. And personally stand by them whenever they are delivering, if I am available nearby. So I am doing this. Regarding the episiotomy, sir, you are rightly said that it straightens, and usually in 95% of the cases we used to give, but as the evidence says, so just I mentioned that if it is not required, and especially for the smaller babies, it is more required. So almost in each and every case we used to give the masterly inactivity and the stipulated time between the delivery of the, means when the compression of cord may be there and up till the delivery of the head is a very crucial point, and it should be taken care. And thank you for your addition of the valuable points.
Then when you started this discussion, one point I will add. If you ask any student in the postgraduate examination, so what is the incidence of breech delivery in your hospital? Let's suppose I do not know about your hospital. Have you seen a breech delivery? Nah, yes. When you have seen a breech delivery and conducted by whom? When the patient has come in second stage of labor.
Definitely, sir.
That is the only thing. Had it been in the first stage, automatically 100% it could have been undergone cesarean section. Fortunately, she had come in the second stage of labor, or you have given a call for anesthesia and there is delay for the anesthesiologist to attend the case. In the meantime, she has delivered. So that is there the two occasions where we see breech delivery in modern day obstetric practice. Jyoti, your hospital might be exception, but I am telling the global truth.
You are right, sir. You are absolutely right.
I am always right.
So, sir, we take permission to close the program now.
I enjoyed,
yes, sir.
madam. Thank you very much.
Thank you so much for your inputs, and thank you. Have a
Thank
very
you,
good.
Dr. Monica, that you have incorporated Raipur Society along with your webinar.
It was
And in future,
total our pleasure, our honor, Dr. Jyoti, and we'll be troubling you and Sahu sir again and again and again.
no, it will not be a trouble. It will be hand in hand coordination and benefit.
Thank you so much. Thank you. Have a very good night. Thank you. Thank you.
Thank you. Good night.
Thank the organizers, thank the speakers, thank the chairpersons, the moderators, all the panelists, and overall ISOPERB on the whole. Once again, thank you.
And long live ISOPERB.
Long live ISOPERB. Yes.
Three times.
Long live ISOPERB. Long live ISOPERB.
Long
live
live
ISOPERB.
That is
Good
my
night.
story.
Thank you. Good night. Good night, everyone.
Thank you, sir. Thank you. Thank you.
Bye.
Neetu, bye.
Bye, sir. Thank you, sir. Namaskar, sir.
Namaskar.